In the mighty name of Jesus Christ, we come before you, we humble before you this morning. We give you every praise and honor because you deserve it, Jehovah Lord. Thank you for this wonderful day. Thank you for every delegate that is here. We are here for a purpose, Jehovah Lord. We call upon your presence in this particular 3 days congregation, Jehovah Lord. May you be with us even as we start, King of Glory. May you see us through the 3 coming days, Jehovah Lord. We want to commit each and every facilitator of this particular congregation unto your able hands, that, Lord, you may give them wisdom. You may help us, Jehovah Lord, even to accomplish the mission that has brought us here. We want to pray for our country, Kenya. We want to pray for the county of Mombasa. We want to pray for all the 47 counties, Jehovah Lord. We want to pray that, Lord, you may start this particular meeting with us. And even as we end it, Jehovah Lord, well, every glory and honor shall go back unto you. May you bless the midwives of this country. May you bless the midwives of this world. We give you praise and we give you honor. And in Jesus' name, I do pray and believe. Amen.
Thank you, Magdalene. And I think now we believe we have started with the Lord. Sindio, we've started with God. And then, of course, tomorrow we are going to make sure that we balance the religion so that we don't feel left out. So firstly, let me welcome you to the 10th Annual Scientific Conference. We are a decade now. Oh, yes. So we are 10 years in being Midwives Association of Kenya, and that's a very big milestone for us. So before I begin, I would want to recognize the counties that are here. County number 1. County number 1, kama uko, just lift your hand. Thank you so much. Oh, ni 001, huh? Oh, thank you, Pole, sorry. Yeah, and then county number 2, Kwale. County 002, kindly. Kwale. Thank you so much for coming. County 003. Thank you so much for coming. County 004, Tana River. Finally, thank you. Thank you for coming. County 005, Lamu. Lamu. Thank you so much. Thank you. County 006, Taita Taveta. Thank you. Thank you so much. County 007, Taita. Taita Taveta. Sorry, 6. Garissa. Garissa, bado hawajaingia. Them they are coming with the reverse gear kidogo. County 008, Wajir. Mandera. Wanakuja na reverse gear, but they'll be here. County number 10. County number 11 is Isiolo. County number 12, Meru. County number 13, Tharaka Nithi. County number 14, Embu. Embu team, bado, wali travel overnight. County number 15, Kitui. Kitui, I know they are here in very big numbers. Kitui, bado waja register. Okay. Machakos, county number 16. I've also seen some of them. Oh, okay, thank you. County number 17, Makueni. Makofi kwao, yes, thank you. County number 16, Nyandarua. Nyandarua. County number 19, Nyeri. Is Nyeri team here already? County number 20, Muranga. Muranga, I know they are represented, but maybe hawajafika. County number 21, Kiambu. They are still sleeping. Traveled overnight. County number 22, Turkana. Kirinyaga County. Ah, okay. Thank you. Thank you. West Pokot. Is there West Pokot around? Samburu. Trans Nzoia County. Uasin Gishu County. People are still registering. We'll recognize them in due time. Elgeyo Marakwet team. Nandi, Baringo. Ah, nice. Karibu sana. Laikipia County. Nakuru County. I've seen them upstairs. They're still registering. Narok County. Ah, thank you. Welcome. Yeah, well done. Kericho County. Kericho County, Kajiado County. Ah, karibu. Bomet County. Ah, karibu, karibu. I know others are still coming as well. Kakamega County. Why are you intimidating us now? Vihiga County. Vihiga County. Bungoma County. Bungoma on the way, Vihiga on the way. Busia County. I'm part of that county, so I have to ahululate. Uongo, eh? I'm in 3 counties, my friend. So I'm part of Busia, Kakamega. I'm in all counties, by the way. So, Siaya County, Kisumu County. Oh, yes, Siaya. Kisumu County. Ah, thank you so much. Yes, they are still coming. Kisii County. Kisii. I thought I saw someone from Kisii. Migori. Homa Bay County. Oh, yes. Yes. Nyamira County. Nairobi County. Ah, thank you. So we wish to welcome you and we want you to feel at home. Kindly network with one another. Make sure you are adopting a county before you leave here. So I would like to welcome the national team. So I would like to welcome Madam Chair to introduce us.
Thank you. Good morning, everybody. Good morning, midwives. Good morning, midwives. Thank you. Thank you so much for coming. I want to take this time to welcome all of you to this conference. But before I do that, I want to welcome our national team. I know we have the Mombasa team that will again welcome them so that they can welcome us officially in this place. Before the national team comes, I welcome the Chair Mombasa. Please step forward so that you can welcome us to Mombasa. Karibu, Chair Mombasa.
Good morning, everybody. Karibuni. Mombasa team, simameni mwakaribishe wageni kidogo. Song, Queen, put a song. A song for welcoming them. Hakuna matata. Hakuna matata. Thank you so much. As the song says, karibuni, feel free, mujienjoy. Mombasa ni mji wa raha.
Thank you so much, Mombasa team. We feel humbled to be in Mombasa again. Actually, it's not easy for a team to hold conferences for 3 consecutive years. I want to appreciate this team, Mombasa, because they have been there for us. They have supported us. They have welcomed us in Mombasa. This is the 3rd time we are coming to Mombasa for this conference. So thank you so much. Let us put our hands together for the Mombasa team. Thank you, thank you. I know we will also give them an opportunity to introduce the planning team, but this morning I just want to welcome all of you to this conference. Feel at home. Jisikie Mombasani. Hello. We have a friend here who is not hearing Swahili, but the neighbor, please tell her when we switch to Swahili what we are saying. So feel that you are at Mombasa. Feel welcomed to this 10th annual conference. I want to welcome our national team, please, so that they can briefly introduce themselves. You know who is in the house. Karibuni.
Good morning, everyone. Hi. Habari zenyu nyote. Niko Western tayari habari. Mnaendeleaje? Mukoko Mombasa. Haya, karibuni Mombasa. My name is Dr. Sally Oronje. I'm the National Vice Secretary, Midwives Association of Kenya. Karibuni sana.
Good morning again. My name is Eunice Atsali. I'm the National Secretary, and I want to apologize for not recognizing our other county. There is our county that is international, and our biggest mother is actually represented here. And we have Zab, midwife advisor from ICM. Official, we have another county actually, Ramka. We recognize your presence, yes, karibu. That's part of us. Actually, we are part of them because we do quite similar things, and we advise one another on so many aspects. And then we have also someone who really takes care of us. We have our partners in the house, but we'll recognize all of them in due course. But one of the partners that I would like to recognize, and you can see, I think their name is so, okay, we've closed that. UNFPA, who adopted us from beginning up to today. We recognize you. Thank you so much. Yeah, thank you.
Thank you so much, Sally, our National Secretary, for taking us through the introduction session. With us, we also have our National Treasurer. I think she's downstairs ensuring that all of us are able to settle in the course of the day. I want to offer apologies, stand on behalf of our National Chair, Dr. Tekla Ngotier. She will not manage to be with us today, but she's with us in spirit. So she will be with us in spirit, but I offer her apologies. And on her behalf, I want to welcome all of you to this 10th annual scientific conference. Thank you so much. My name is Catherine Shienji. I'm the Vice Chair, Midwives Association of Kenya. Thank you so much and feel welcome. Thank you. Eunice, back to you.
Thank you so much. Thank you. And right now, I wish to remind us that we've come to do what? What have we come to do today? For the next 3 days. What are you going to do for the next 3 days?
I'm shy.
Yeah?
Niko shy kuongea mbele ya watu. I'll learn, relearn, and learn again.
She's going to learn, relearn, unlearn, and relearn. Okay. Thank you so much. The other thing we are going to do is networking. Sindio? But based on the learning, the person in charge of the learning, mmesikia kijia ita nani? Dr. Sally. So I want to hand over to Dr. Sally, the scientific team coordinator, so that now she can start her thing. Thank you.
Thank you very much, Eunice Atali, and thank you everyone else for arriving this morning for us to be able to start our sessions. I know this is a very important day that we will be officially opening, but before that we need to do activities in the morning. This morning, I and Dr. JJ, please come over, will be doing the morning moderation to ensure that we are able to do a quick learning of the sessions in the morning. Allow me to give a few preliminaries. Kindly, if you have a presentation, ensure you send your presentation or see Lamek and Fidel at the corner. Lamek and Fidel, kindly stand. Lamek and Fidel at the scientific corner. That's a scientific corner. So if your presentation was not sent prior, kindly make sure you send your presentation to Lamek and Fidel. And of course, with the your biography. Again, we would request RHNK member to kindly ensure your presentation is upfront, because you will almost be coming as quickly as possible. Number two is that we have poster presentations. The poster presentations are going to be in fast flow. Kindly get in touch with Fidel. You will be given a tape so that you can post your presentations on the second track. We will have second track tomorrow, so we will have first and second. So today our posters will be downstairs, where we'll also have our tea. We have the washrooms downstairs, so we can use the washrooms downstairs. We'll have a direction on the same down and even fast flow, so that we can minimize the ones on the upper side. But still, you're free to be able to use the washrooms up here. Thank you. So I will allow Dr. JJ, to invite the next presenter.
Thank you, Dr. Sally. Good morning, midwives. Good morning. Welcome to our 10th annual scientific conference, and we are very privileged this morning to have our first presentation. Our first presentation is a panel discussion from JPIGO. So JPIGO team, you could be coming over. And the panel discussion is about continuity, choice, and care. Rethinking post-pregnancy, family planning, service delivery. This is a key area that many a times when women have given birth, we just leave them to go home without thinking what is happening to them after. So this team is going to help us dissect that and help us know what do we need to do in terms of continuity of care and the choice. Karibu.
Before you is a panel team from JPIGO. JPIGO works hand in hand with the national government and the county governments in improving maternal and newborn outcomes through implementation of various programs that support the maternal and newborn health. And today our panel discussion title is Continuity, Choice and Care, Human-Centered Care for Women, Their Families, Experiences from Post-Pregnancy Family Planning and Obstetric Safe Surgery Projects. Continuity of care is essential in ensuring that every woman has access to timely, respectful, and informed post-pregnancy family planning, that is PPFP, and cesarean section. However, gaps often emerge in access for safe cesarean section and anesthesia care. In post-pregnancy family planning, women transition from facilities back to their communities, limiting opportunities to exercise informed choice and sustain healthy birthing spaces. So this panel today, this morning, is here to examine how we, midwives, the community health promoters, youth advocates, and male champions can strengthen the linkages across this continuum of care to ensure women's needs are met from delivery through postpartum follow-up. The panelists will reflect on approaches that enhance informed choice, integrate culturally sensitive practices, and leverage innovations such as digital tools, peer networks, and male involvement. So with me this morning, is myself here. I'm with us. My name is Sylvia Lanya Mutisia. I'm a Kenya registered community health nurse working with Makueni County. I work in a sub-county called Kibwezi East, where I work in a level 4 hospital called Kibwezi Sub-County Hospital as the maternity team lead, as the deputy nurse manager, and also coordinate reproductive health services in the sub-county. I am a very passionate midwife. Matters pertaining maternal newborn health are part of my heartbeat, and I'm a student currently at Amref International University, pursuing my Bachelor's of Science in Nursing. So today, with me on my far left is Mary Mudengi. Mary Mudengi is a passionate midwife. She's working with Japaigo, and she supports maternal and newborn care programs. She's a technical officer and oversees implementation of obstetric safe surgery, that is OSS, and ampli PPHI projects in Nakuru and Makueni counties respectively. In her previous assignment, she implemented obstetric fistula, that is OF, and OSS programs in Makueni County. She has a Master's of Science in Clinical Investigation, Global Health Innovation and Technology, and a Master's Certificate in Nursing Management. She holds a degree in Bachelor's of Science in Nursing. She has extensive experience in working NGO, public, private, and faith-based sectors with over 20 years as a nurse, a midwife practitioner, and a midwifery tutor. She is a trained mentor in Ramka and very passionate in saving lives, mental health, documentation, advocacy for policy change, quality improvement, and innovations. And she lives by the motto, limits are unexplored zones. Let's appreciate Mary Mudengi as she takes us through our very first question. So Mary Mudengi, how can we improve maternal newborn outcomes through the obstetric safe surgery, whereby we explore digital platforms, peer networking, and youth engagement?
Thank you so much, Sylvia. Japaigo is an international NGO working in over 40 countries in Kenya, and also on maternal and newborn health. And in Makueni and other counties, we are implementing different projects. And not only in Ramka, we are in Wash, we are in space, and also and global security. Basically, that's a snapshot of what JAPIGO does. So for the obstetric safe surgery program, we know that obstetric safe surgery, if the mothers don't get access to safe, timely, and quality cesarean section, they die, or they have morbidities where you cannot take care of them. And in our settings, 85% of all the operations, you can give me witness, it's all cesarean sections. You can have theaters, you can have medical officers, but they will do the cesarean sections. And we know that cesarean sections avert morbidities and mortalities for 25 to 30% of our women, and between 30 to 70% of newborn mortalities are associated with untimely cesarean section. So for obstetric safe surgery, there are different approaches, and one of them is about patient safety and clinical standards, where we train a multidisciplinary team in terms of the anesthesia care and the surgical skills. Because we have realized people in theater have been left behind when there are trainings in RAMCA, in BMOC, and by the end of the day, when we get about outcome in theater, we tell them to resuscitate the baby and the mother. So what happens if they don't have the skills? The skills in terms of, we are from different schools of knowledge. We got training by different mentors, and our surgical skill might be different. And that is why we bring even the medical officers, so that we can talk together. Shared decision-making for these women and consented care. By the end of the day, it's respectful maternity care, because our women are enlightened, and we should give what we ought to be given when we are in that space of a patient. The other thing we do in obstetric safe surgery is IPC, where we have IP bundles, where it includes the preoperative antibiotics, the vaginal cleansing, and the abdominal prep, and also the post-care of these women. That continuum from pre, intra, and post, where we track women for surgical site infection. Then documentation and clinical listening. Do we have data registers in our setting? Or we are using black books? Do we track these women, or we wait for them to come back on day 14th? When we don't know even the outcome? What of the neonatal deaths we get in the community? Do we have an accurate figure to go to the DHIS and inform policy? So we have introduced some data in those two counties where the RAMCA division will take it up and make sure we have standardized tools so that we can communicate on policy and advocacy when we are talking about mortalities and morbidities of our women. Then the other thing is about capacity strengthening and mentorship. We know that after you are trained, you don't retain the skill. That is why it is important for a person to take you through the processes, because sometimes you can forget. So we have a mentorship structure where you use the hub and spoke model. The high volume facilities support the low volume facilities, and it is on a monthly basis, and we have used a braided approach where we have both in-person and virtual mentorship structures, and we have tools where we gauge their knowledge retention and also the gaps in implementation. The other thing is about the patient-centered care. How many times are we involving the client's relatives, the companions in decision-making? Or it's a matter of telling a woman, unajua wewe unaenda CS, usipoenda utakufa. So in that time, we ought to know that we have to do that consented care for, and also for the companions who bring her to the facility. And by the end of the day, where do they go? How do we link them to the community so that it is a loop which is not open? And in case of any complications, do we have networks of care, the referral systems? We know that our patients don't belong to public facilities only, but they also belong to the FBO, to the private sector. Then the system strengthening. When we talk of system strengthening, we do the baselines, and we talk in terms of the capacity for the facilities. So in terms of the innovations, we have different platforms we are using. We are using the Proximi platform, where you can do a virtual scrubbing and you can support from any part in the world. Then we have the Surgery Hub, where we do like modules and you get certification for that. And you can also log in and support another person in another region or in another country. Then we have integrated with the prompt system from Jacaranda in terms of the tracking of women, and they are being tracked for surgical site infection after cesarean section. Then we have the WhatsApp group where we can utilize in terms of talking about our challenges, what we can do to improve our facilities, and we know that MPDSR has taken that form, and also the Zoom platforms. Then the e-patographing, where we have to be live. We document not from but on what we have done in our patients. Then the other thing is men engagement. We have left our men in the care of our women. How do we bring them on board? We have male groups where women talk and they come as companions. Then the use of media, because media can give information which is not right, and it brings a lot of stigma and misconception. So we are doing that to demystify the myths and misconceptions about cesarean section. Thank you.
We can give her a wonderful clap, just realizing that a lot can happen to ensure that everyone is on board when we are taking care of our women and our newborns. It can never be a one-man show. It calls upon involving multidisciplinary teams in order to get quality. It calls upon training, retention of skills, follow-ups, and all that Mary has talked about, and working in a county that Mary has been supporting. I can attest that those things have been happening and they have contributed to our good maternal and newborn outcomes. Our next panelist is Madam Jen Wausi. She's also a technical officer with Japaigo under the EPIP project in Makueni, and she is a midwife, committed one, and a public health expert with extensive experience in reproductive and maternal newborn health. She's deeply passionate about women's advocacy, particularly promoting autonomy, informed choice, and access to respectful rights-based care. Jen will take us through on how best we can integrate PPFP into health systems and community services. We realize that after our women come to give birth in our facilities, they go home without a family planning method, and that is a missed opportunity. And they come back again pregnant. There is no healthy timing and spacing of their pregnancies, and we end up going into obstetric emergencies. Knowing that PPFP, the immediate one, is a low-lying fruit because the clients come to our facilities and we can be able to counsel them, they consent, and they get the method as soon as they deliver. So allow me to welcome Madam Jen Wausi to give us some insights on what has been happening around that area. Give her a round of applause, please.
Thank you, Sylvia. So I would want to talk about one of the projects that we have as Japaigo. The project is called APIP. APIP meaning Accelerating Post-Pregnancy Family Planning into Primary Health Care in Kenya. So we are a Gates-funded project implementing in 4 counties in Kenya. That is Kakamega on the western side. We have Makueni. We have Kwale in the coastal region. Then we also have Isiolo, which is on the Asal side. So what we are doing is just like what Sylvia has mentioned, how do we integrate post-pregnancy family planning into the services that we offer as midwives? So when we talk about post-pregnancy, we mean both postpartum family planning and post-abortion family planning as interventions that are key to reducing maternal and newborn mortalities in Kenya. So we are in those 4 counties and also supporting the national level. We understand the role of family planning as an important intervention in reaching the SDGs and also our family planning 2030 goals as a country. So the current gaps that we have in Kenya is the low uptake of postpartum family planning among women who are delivering in our countries. So according to the KDHS 2022 that was released, we realized that our MCPR, or our modern contraceptive rate, is quite high. But when you look at the gaps that we have, the unmet need that we have for family planning in the country, it is among the women that are delivering in our facilities. So Kenya, we saw that we have a very high skilled birth attendance within the facilities that we serve. And we saw that within the KDHS that was released. So now the gap that remains is, are these women getting comprehensive care within the maternities that we are in? So if this woman is delivering in the maternity, are we able to ensure that she leaves the maternity unit with a contraceptive method? Are we able to counsel them? Are we able to see that they do not need to go and make a queue in the MCH after 6 weeks? Are they aware that they can start a contraceptive immediately after delivery or even during procedures like cesarean section? Do our women know that? Do our midwives know that? Are we also implementing that? So this is why we have the APIP project, and it's trying to see that women within this country are able to get these services, comprehensive services, within the maternity units. And this also goes for women that have lost a pregnancy, whether intentionally or not. So post-abortion care within our gynecological units and also within our outpatients units. So where we are doing the MVAs, are these women able to get a contraceptive method within that unit before they leave this facility that they are in? So this is what this project is supporting. And also we are in line with the national goals for Kenya within the DRAMCA department. So our biggest success is just to show integration of these services. And this is within the outpatient for PAC, within the labor and delivery units for women that are delivering. Are we able to give that PPIUD within 48 hours? Then also post-delivery within the postnatal clinics, are we able to give or cancel even on just contraceptive initiation at that point in time? Then throughout the continuum of care for this woman who has delivered up to 1 year, whether they are able to get counseling and actually receive a method of family planning before they get accidents. You know, we get accidents in Kenya, right? You have just delivered, and before you even come for the clinic, you realize there's someone who is kicking before we actually even come for the first immunization for 6 weeks. So it has been, we know even some of us are culprits, right? We've been there, we know how it is, and it's a tough one. So if we are able to initiate a contraceptive method at that point in time before we actually get an accident or an unwanted pregnancy, then that would be fantastic. We imagine the women that have had an abortion, whether intentionally or not, and especially for the ones that have done comprehensive abortion care. Do we do the counseling? Do we tell them that there is an opportunity for them to get a contraceptive method immediately after an abortion? Are they aware, or are we still battling with the barriers and the myths and misconceptions that surround initiation of a contraceptive method after an abortion or immediately after a delivery? So we have barriers and challenges that we've met throughout this program, and some of them are related to limited counseling, where our mothers are not receiving enough counseling during these 2 periods. Myths and misconceptions among ourselves and also within the communities that we serve, that we cannot initiate a family planning method immediately after an abortion. And this is related to the fact that we say you need to deliver another one immediately in most communities, and especially the Kamba communities where I come from. In Makueni County, you are told, kama hiyo imetoka, ongeza ingine haraka, haraka, haraka. So then the other thing that we are battling is cultural norms around initiation of contraceptives before 6 weeks or even within the first year after birth. Then stockouts of these commodities, and I know Alice will speak into that. Do we have the JADELs? Do we have the DMPA that we are supposed to give to these women? Something else that is quite important to us as a team is male engagement. Are we talking to the males? Are we engaging them? Are they aware that we can initiate contraceptives at these 2 points, when we lose a pregnancy or even when a woman delivers immediately? So some of the best practices that we have seen is working with low-lying fruits, the fact that we have high-skilled birth delivery in the country. We can initiate PPFP within the first 48 hours before this woman leaves the facility. And this can be seen through data in the 4 counties where we support. PPFP is quite high within the first 48 hours. The women are willing to take up the method. And because we know family planning is a choice, it is not being forced. But during this particular time, most of the women are willing to take up a contraceptive. Then another thing is we have implemented blended learning. So currently we are not supporting any trainings, classroom trainings for contraceptives or long-acting and reversible methods. What we are doing is blended learning and mentorship. So you take an online course around family planning, but then we combine that with skills within your facility, with the mentors that you have in that facility, then you implement that within your facility. So this has shown a great increase in the uptake of PPFP in these counties. So we are also cascading this at different levels. At national level, we are working to work on policy and advocacy to see that PPFP is in all our documents. Currently, we are working on a national strategy for implementation of PPFP across the counties. So you will see this policy coming in and know that this project was quite key in supporting that. At county, we are supporting counties to have an FP budget line, plan for the mothers, let them have family planning before they leave that facility. And this is also taking advantage of what SHA has, because SHA is also supporting PPFP within 48 hours before a woman leaves the facility. At county level, we are implementing and we are supporting integration of family planning into these areas that we've talked about during ANC for counseling, during labor and delivery, postnatally, and even within the first 1 year before that baby gets before the mother clocks 1 year post-delivery, and also for women that have lost a pregnancy, that they should have initiated a method within the first 7 days. So that is what we are doing as an AP project. So I'll pass it on to Sylvia. Thank you.
Thank you so much, Wausi. That was quite rich. And I know counties 017, Kakamega County, Kwale County, Isiolo County, can attest to what is happening on the ground, and I will request us to interact with those teams so that they can also tell us how they are implementing this in their various facilities in their counties, and we can borrow from such good work. Our next panelist is Jefferson Kioko. Jefferson is a nurse midwife. He works in Makueni County. He has a Bachelor of Science in Nursing from the University of Nairobi and a diploma in Kenya Registered Community Health Nursing from KMTC, Machakos, Kenya. He is trained and experienced nursing officer with over 13 years of clinical and community nursing practice. He is passionate about advancing knowledge and skills, and he in the nursing field through leadership, mentorship, capacity building with a strong focus on reproductive maternal child health. He supports his sub-county as a sub-county reproductive health coordinator in Mboni sub-county, Makueni County. He deputizes the nurse manager at Mboni sub-county hospital and also the maternity team lead in Mboni sub-county hospital. He also champions gender-based violence coordination of activities in the sub-county. He's a mentor in family planning, EMONC mentorship, and even bleeding after birth. And he's also a trained EMONC mentor. Allow me please to welcome Jefferson to give us insights. Being a hands-on person, how has implementing these programs been in relation to bridging the gaps that Wausi has talked about, the myths, the lack of male support? How are they involving male partners or male companions in the care of these women on the ground? And what are the best practices that they are having, including even the engagement of the CHPs? Allow me to welcome Jefferson. Please give him a round of applause.
Good morning. Introduction, as you have heard, I would like to stand while speaking to tie break. Since I'm tie breaking the perineum, I'm also tie breaking by standing. So I'm on the ground where the two programs are being implemented at the sub-county level and at the facility level. I would like to mention something where Madam Mothengi left about OSS program. There is the latter part of continuum of care, whereby we track the mothers as they are discharged. On 7th day, we call them and ask them, how is the baby? How is you? How is the incision site? How is the cord? How is the lochia? Using a language that they can understand. And through that, we are able to identify SSIs as soon as they happen. The two programs are working hand in hand with the national government. They have been able to review the registers. And for example, the one for OSS, they brought in theater register with a column for attachment. That is the only new thing that they brought. You know that immediate attachment and breastfeeding is very key within 1 hour. So that is the thing they brought on the register. We use CHARs and CHPs also to track. Those who we are not able to reach them through the phone, they trace them physically. Now on APIP, there have been also new innovations. Like for example, in the new register for family planning, together with the national government, they included the column for spacing, whereby we talk about 6 weeks to 1 year, immediate postpartum. They brought a new code. Like for example, code 1 on that column is about immediate postpartum. Code 2 is 3 days to 6 weeks. Code 3 is about postpartum care, post-abortal care, post-abortal family planning. Sorry, you have heard from our house. And then code 4, 6 weeks to 1 year. Another innovation is about a stamp in the ANC, whereby after counseling a woman or a client on family planning method, you stamp and indicate which method the client has chosen. That makes it possible for the person in maternity to identify a client who was cancelled prior and maybe the method that she chose to use postpartum. Then a continuity of counseling takes place there and the mother goes home with a method. We have heard about male, that I'm supposed also to talk about male engagement and youth empowerment on SRH, on family planning, on these two projects. And for the youth, I would like to say, it's all about having clinics that are youth-friendly. Clinics that are youth-friendly in our facilities. Do we have? Are our clinics youth-friendly? Yes, no? They are. Yes. How do we make them youth-friendly? We ensure that information is not limited to youth, so we give them appropriate information in the way they would like to hear. We ensure also that commodities are available. We ensure also the services are accessible at the facility, among others. So I'll go to main champions on family planning. As you have heard, one of the barriers is gender roles, whereby men have a great impact on choices our women are making. Maybe a woman will not choose a method that is feasible in fear of the man in the house. So we need to bring men on board to bridge such gaps. How do we do that? In our county, 017, we have around 18 champions across the county, and we use them to pass information to other men. And for men empowerment, one thing that we have done is that we ensure that we choose somebody who is a public opinion leader, a political person, when choosing the champions. For example, if you go to our county of Makueni, you will find that the governor is a champion of these programs. The governor will tell you about the HAPIP. The governor will tell you about its stable Kabetocin. Then the champions, another thing that they do, they attend men's gatherings, pass information, discuss with men about family planning. Another way we can bring men on board is clarifying family planning information to them. Some of them fear family planning because of the myths that are existing. For example, can you imagine when talking to men about vasectomy? Most of them will think about castration. So you need to empower men with information, and give them the right information.
Thank you so much, Jefferson. I know he really has a lot to share, but in the interest of time, we will be interacting with Jefferson in our midst as we get to learn more what is happening in Makueni. Allow me next, our next panelist, Beverly. Beverly is Kakamega, and I would like to give us insight on how carrying out improvement in maternal newborn health as far as linkage with the community is concerned. Karib.
Thank you so much, Sylvia. And because the ones who started speaking before me have taken part of it, so I just want to talk about the household follow-up and continuity of care. So why does household follow-up matter? That is because most of the time when these women deliver, some of them after discharge, they will never come back to the facility again. So it is important that we do the follow-up and ensure that we are following them to know how they are continuing the life. So in the household follow-up, that is where we find the women in their safe space, and we are able to discuss with them about the family planning and also to ensure that we know whether they took a method on discharge or the method was not taken. So in the follow-up, we are ensuring that we are doing the integration. And in the integration of postpartum family planning, we are not waiting for the mother to deliver and introduce the message. So what we are doing is we are starting to introduce the postpartum family planning discussion when the mother is carrying the pregnancy. This is again emphasized during delivery, and by the time the mother is being discharged going home, the mother has a method. This is also done to ensure that we also train the community health workers so that they are able to give the short-term method and also link the mothers to the facilities for the long-term methods. So what we are just emphasizing on the follow-up is don't stop the postpartum family discussion at the facility, but we have to emphasize and follow it up to their homes and ensure that we are not stopping the clinical management at the facility level, but we are emphasizing it up to the community level. Just to sum it up, because I'm being forced to stop at that point, I'll stop by saying, Magare Madai formerly said, when women can plan their families, they can plan their lives. It starts at home. Household support is where these plans become a reality. And we cannot have maternal health without reproductive health. And reproductive health includes contraception and family planning. Thank you.
Wow, a round of applause for Beverly. Allow me quickly to welcome in Alice. Alice is from the Division of Reproductive Health, and she will take us through how policy and financing structures embed continuity, choice, and care within primary health systems in the next 2 minutes, kindly.
Good morning. Yes, I'm addressing the question, are national policy frameworks and financing creating an enabling environment for continuity of care? Is it ensuring equitable, sustainable PPFP and obstetric safe surgery? I'll try within 2 minutes. Policy frameworks and commitments. Kenya policy aims to integrate post-pregnancy family planning into routine care to ensure that all women have access to quality rights-based family planning services during the continuum of care, starting from preconception, ANC, intrapartum, and postpartum. The government is committed to integrating PPFP into its maternal and child health services to ensure access to services during and after delivery, and including utilizing the safe surgery, where we can have some of the methods being administered. Family planning is also viewed as a rights-based issue and a critical component of achieving the universal health coverage with the goal of ensuring equitable access. Now, for the policy framework and commitments, I know we appreciate that family planning, which is being, the intervention is PPFP. Family planning makes a 30% contribution to the reduction of maternal mortality, and we cannot ignore it. And it's helping us to contribute to the global targets of zero unmet need. It's helping us to, various interventions are helping us to do zero tolerance to SGBV, the 3 zeros, which I'm aware you're aware of. So the emphasis, policy-wise, is that we need to increase access to PPFP services. And where you see a woman, please provide a method. We need to improve the method mix, and in Kenya we have added 2 new methods. We have the DMPS, subcutaneous, you know that, and we have the hormonal IUD that has been added to the method mix because we want a choice. Ensuring commodity security, its availability is one of the key aspects the policy addresses itself to. And engaging men in decision making is very important. We can't move without them. Providing comprehensive education to reduce the unplanned pregnancies, improving maternal and child health outcomes. I hope I get to the call to action for midwives before I'm stopped. So the National Reproductive Health Policy 2022-2032 is very pivotal in this, and it has addressed matters concerning everybody in the space of reproductive health. And the key strategies for this policy, the policy reaffirms the commitment to universal health coverage, and it recognizes FP as a fundamental right with a commitment to providing the services, and it aligns with the Sustainable Development Goals, the SDGs, that we are contributing to. It emphasizes a shift towards preventive and promotive healthcare, and it cuts across national, county, sub-county, up to the community level. And the key strategies covered under this policy is improving access, expanding method mix, ensuring commodity availability, improving health systems and data. Data is a unit of measurement, so we cannot run away from data, and we have tools that the national level has ensured they are revised to speak to the policy concerns. We cannot ignore provider training. We need sharp, skilled, competent workforce to be able to get it right if we are going to realize the goals. We need, across all packages, be it FP, MNH, we need a trained workforce, and we need linkages. We cannot do without linkages. Maternal and newborn health linkages are very important to leverage on opportunities during the postpartum period to assess and provide FP services. And this is a focus for improving maternal and child health. Secondly, we need to address social determinants and behavioral factors. That's where the community comes in, the male engagement, the comprehensive messaging. We need messages to cut across. Financing and policy advocacy, we need to increase domestic funding, and there are efforts around that. In fact, we are even looking for the insurance companies to fund family planning and RH services. Multi-sector approach, we need everybody, and you're a key stakeholder. So then, what is the role of the midwife as a stakeholder? We are meeting midwives today. We are midwives. what is our role? Kenya policy encourages the midwives to integrate PPFP in any spot where you see a woman. You need to talk to her, ask her about, is she doing family planning? Is she safe? Midwives are called to provide counseling on and access to full range of the choices, including the immediate postpartum. Immediately the client has the placenta out, the story begins. The role of the midwives, therefore, is to ensure there is integration of service delivery, there is counseling on FP provision, there is addressing missed opportunities. Now that women are really delivering under skilled care, we need to make sure that no one misses an opportunity, working towards zero unmet need for family planning. Next is collaboration and linkages. We need to collaborate, we need to link. The midwives are very pivotal in this. And we need to strengthen postpartum care and promote immediate postpartum. Then we need to support and we need to do mentorships. We need midwives to do mentorships, and we need to strengthen community linkages. And lastly, we need to see how we can tap into the obstetric safe surgery. We need to make sure that there is quality of care. We need to make sure that we can have family planning options introduced at that level. And so all of us are called to promote PPFP because we need to reduce maternal mortality, which is escalating. The trend is reversing. We need to make sure that we take advantage to reduce the 10%, the 30% cost, which is unmet need for family planning. Thank you for listening.
Wow, that was so amazing. Thank you so much, Alice. You have really tried to sum all that up for us. And our call for action from Madam Alice as midwives, we have a role to play in all this. It starts with you as a midwife and me as a midwife to ensure that we give the necessary services to our clients. I don't know if we will be given a time for Q&A or we will be interacting with the participants later on. Do we have anyone with a question to the panelists? Anyone with a question to the panelists of today concerning postpartum family planning? There is a hand. We will take one or two questions. There is someone with a question. Go ahead.
Good morning. Yeah, my name is Anderson Kimeshwa, nurse wife from Tiati. I really want to appreciate the panelists for really digging deeper into this issue of post-family planning, and specifically to speak about male involvement. I come from a community where paying dowry is extremely expensive, where sometimes you're required to pay 30 cows, even to around 60 goats and camels. So sometimes the interest of those, especially the male, is that they want to see their women giving birth. And sometimes even to make things worse is that when they are negotiating for bride price, is that they do not, for example, even share those cattle. They wait until when they, maybe when that wife gives birth. That is when they can start enjoying now the fruits of dowry. In a situation whereby the wife do not give birth, then there is always chances that that dowry can be returned back. So now to the question of family planning, where we really need to involve the male, because this is a very sensitive issue, and just as you rightly put it, is that we need to use the influential, maybe male in the community, and sometimes even initially, at some point, one of our staff, I think, was threatened many years ago because of just giving up family planning. So the issue of cultural, aspects plays a very key role to our, because I've come to realize that this is a service that is denied to our women, because you have maybe the packaging of the information should be the issue of planning is the issue of child spacing. But now to them, they always don't want to that issues. So I think, I don't know what the panelists can address, maybe on top of what they've said regarding maybe those cultural, where people are so strict that even they don't want to hear issues of planning. Thank you.
Thank you so much for that question. I know the panelists have gotten it and noted it down, and they'll be responding. We'll take another question, kindly.
My name is Eileen Sawani from Kajiado County. My question is the role of the midwife, especially in the quality of data. I think the first facilitator talked about that our uptake of PPFP is very low, but that could still be the other way. We could be giving the service, but the kind of quality of data that we have is very wanting. For instance, if you look at the MOH 512 and the MOH 711, the data that we capture from the register in 512 does not agree with what we're supposed to do the data entry in MOH 711. So we could be doing a lot of work, especially as midwives, but our quality of data may not give us what exactly we want. So my question is, what would be the role of the nurse in making sure that our data is quality, and especially in relationship to working with the other cadres that are concerned with data? Because if we look at the EMR systems that have been introduced in different countries, especially in collection of data, does not capture everything in 512, and that leads us to missing a lot of data. Thank you.
Thank you so much for that question. I know it has been captured, and allow me to give the panelists. We can take a third one, then our panelists can respond.
So thank you very much. My name is Juliet from Busia County. I just wanted to probably look at the policy, and I think that it's high time the policy makers look at family planning versus the underage children versus poor maternal outcomes, because you realize that when you look at my county, Busia, the sexual debut for the young girls is 8 years. So it's important that probably if we could have a policy guideline with regards to family planning, the underage children versus the teenage pregnancies. Thank you.
Thank you so much for your question. The very last one.
Good morning. I'm Aisha Abdi. I'm a nurse educator from Mewa College of Professional Studies here in Mombasa. Thank you to the panelists. My main question today is, we were talking about mentorship and training, but majorly it's focused on the workforce, the nurses, the clinicians, the community healthcare workers who are already qualified. So how are we bridging the gap in the training institutions? Thank you.
Thank you so much for that question. Allow me to give the panelists time to respond.
Thank you so much for the questions. The role of midwives in data. We know that you are 24 hours in a facility. And if you are not, in our lower facilities, level 2 and level 3, you are the key custodian of the data. So the question we need to ask ourselves, do we have the tools? Are the registers there? Because if you don't have the registers, the summaries will be an headache to you. The ANC register, the maternity register, the postnatal register, the theater register, the tracking registers. And by the end of the day, are they reflective of the summaries? When we are doing the candexes, because we know there are litigations in all over the place in terms of patient quality of care and mismanagement, are you documenting what you have done in our candexes? And if it is online, is that reflective of the activities you did to that patient and the procedures? The other thing about data is about the service delivery point. We know that in some areas it might be a standalone service delivery where you have different units, and by the end of the day there is stockpiling of the data. How do you make sure that by the end of the month you congregate this data together and bring it up to the national mechanism and the data summary tool, MOH 711 or any other data tool, so that it can be a reflection of your workforce in the facility? In terms of documentation and audits, do you have DQS in your facilities where you discuss about data only, from the maternity units to the labor units and also to the ANC? And also, do you link with the community focal persons in terms of the referrals? Because by the end of the day, the data from the facility should talk as a continuum. And remember, trash in, trash out. Whatever you put in there, if it doesn't make sense, it will not make sense to the person on the other end. And whatever is not documented is not done. So we are the custodians of data. Let's embrace that so that we can inform policy, advocacy, and research. Thank you.
Thank you, Mary. I think I wanted to add something on top of data, that currently you're aware that the ministry is rolling out Tibabu or Taifa Care, and some of the counties have already started implementing. So we are hoping to see that now we will be having actual data, because every single patient that comes into the facility will have to enter into the system. So that will make summaries much easier. We are yet to see what that looks like, but a digital health system is the way to go, because currently everything is digitalized. So as all the counties start rolling out Taifa Care, then we should be able to see consistency in terms of data, because all the clients will be within that system, because they must be in that system. Otherwise, you may not be able to get reimbursements for SHA or for any other insurance that will be, or any payment scheme that is working within your facilities. So I hope you have been able to answer that question. So I'll go to the first question that was asked around male engagement and how we are doing it. So in the areas where we have issues around cultural norms, myths and misconceptions, and gender issues around decision-making by families, and we know that these are key issues, especially in areas where we have Muslim communities, and generally within the sub-Saharan Africa, where males are predominantly the decision makers in our families. So the message that we have around is very custom-made, and we are talking of healthy timing and spacing of pregnancies, as opposed to talking about family planning, which sometimes most communities understand like it is population control. So the message that goes to the community is more of, we are helping you to time your pregnancies and to space your children. So that message resonates very well with the males and also among the Muslim communities. So also in these areas, you find that the women have to wait until 40 days for them to do anything. So they can't visit a facility, they're basically at home healing. So what we are doing for them is initiating or continuing with the counseling after they have come back. So like we talked about, PPFP is within the first 1 year for postpartum family planning. So it is still a duration. So at that 40th day, when now they are back to normal activities, counseling for family planning now continues. It never stops, because you can cancel a woman today at ANC, cancel her during labor and delivery, she still says she's thinking about it, then you cancel her at 6 months, because counseling is continuous, and at 6 months she tells you, oh, now I've made a decision, I'll take an implant. So it's based on choice for the client, and is also based on timing. If that's the time that she wants to take up a family planning method, then that's the time that we work with. So something else is also, we are engaging the males like we mentioned, and these males, we are also looking at who are the gatekeepers within these communities. So especially in Muslim communities, we are working with the sheikhs, like in Isiolo, and the message that we are preaching is there is a need for healthy timing and spacing of pregnancies. And that has solved family planning in those areas where it is a choice, and the understanding that it's not population control, but it's just that you are able to time your pregnancies and space your children, and you are good to go. So it is very context specific. How you speak about contraceptives in Nairobi is very different from how you will speak about it in Isiolo. So thank you.
I think we have a question that was touching on policy, and just allow me a minute for her to respond to the question, please.
Thank you, Sylvia. Thank you. Very pertinent issues are coming up, good questions. Just to throw my weight behind male involvement, or is it engagement in fertility regulation. We need to have men. And policy has addressed the issue of male involvement, including addressing reproductive coercion and intimate partner violence, because it's a lot of violence and it's affecting method choice, method uptake for family planning. So yes, we need to get creative around how do we get men on board, because they are the ones who own the kitchen, the money that women need to facilitate them to achieve their reproductive goals, and they are a part of it. About data quality, just to add, I know we have a problem with the MOH 711 data tool, and we are working towards its revision. So any recommendation you give to us, that will be precious. We will be able to take it into consideration. The question on the young, the under 18, yes, I know there may not be policy gap as such. It's a matter of clarity, and there's an upcoming family planning policy. We hope that it's going to shed light so that Busia and every other colleague, midwife, can be able to be guided. And lastly, training. We need training. And about skills, we are working with the in-service. I think we are almost sorted, because we have managed to address various aspects as guided by the policy in capacity building, and we have training packages across all these strategies. How are we engaging the in-service wing? Yes, Nursing Council should attest to the fact that we are working with them to revise the curriculum so that somebody does not graduate today and they are due for updates. They are due for training. So there's that effort. We are also engaging, Nursing Council across our programs. And just to add on that, we are also engaging the various owners of the curriculi, so that we can be able to update the content, so that we are moving together, so that both the pre-service, the in-service wing are reading from the same script. Hope that was useful. Thank you.
Wow, thank you so much. Can we give them a big appreciation for the good work? And just to thank our coordinators for allowing us a few more minutes. I know our call to action, our panelists from the Division of Reproductive Health had already talked to us about it, and I know we will continue to interact as we continue with the conference. Thank you so much for your participation, and thank you to our able panelists. We can have our seats.
Wow, thank you. Thank you so much, Japaigo, for that great panel discussion. It is evidence that they do a lot, spanning from safe surgery, community engagement, male engagement, you know, all those person-centered communication. So we appreciate what you do. We'll have another presentation. This is not a panel, but a presentation by Reproductive Health Network Kenya, RHNK. And our presenter is going to talk about the role of midwives in safe self-care. I know midwives, it is important for us to think about ourselves. How do we take care of ourselves? So we are going to have that presentation. And Lynn is going to take us through. So Nancy Lynn, karibu sana. Nancy Lynn Kavuka. She currently serves as the Service Delivery Manager at RHNK, where she leads and coordinates the effective delivery of reproductive health services across the organization. She brings a strong academic background in the health systems and public health to her leadership role. She holds a bachelor's in health systems management from Kenya Methodist University and is currently pursuing a master's in public health at Amref International University. With her expertise, she bridges the system efficiency and public health strategy, and Nancy is well equipped to drive improvements in service delivery, quality of care, and health outcomes. Her combined educational training focused on both the management of health systems and broader public health systems and public health principles positions her to address complex challenges in delivering reproductive health services effectively and equitably. Let's join hands to welcome Nancy.
Thank you so much. Good morning, distinguished colleagues, members of Midwife Association of Kenya, partners and invited guests. On behalf of Reproductive Health Network Kenya, I am honored to join you today at this 10th Annual Scientific Conference and General Meeting. Allow me first to congratulate Mark for consistently providing a platform where midwives, healthcare professionals, researchers and stakeholders come together to advance maternal and newborn health in Kenya. The theme of this year conference, Midwives Collaborating for Resilient Health Systems, could not be more timely. It speaks directly to the heart of what we as reproductive health professionals are striving to achieve, the resilient system where midwives are empowered, supported, and equipped to save lives and improve health outcomes. So about RHNK, Reproductive Health Network Kenya is an non-governmental organization of over 600 trained healthcare providers. So we have cadres from gynecologists, midwives, nurses, and clinical officers who are spread across the country. Out of 47 counties, we are in 44 counties in Kenya, and we are united by one commitment to ensure access to comprehensive sexual and reproductive health and rights for all. Our vision and mission are so simple yet profound. So we are looking at a healthy society with comprehensive reproductive health services. And part of what we call our affiliation is that we are a member associate of Planned Parenthood Federation. We are a member of Reproductive Health Supplies Coalition and a member of RAMCA, and also member of Sexual Reproductive Health Sites Alliance. So our vision and mission core values, of course, we are bound by professionalism, offering quality of care, right to choose, accountability, equity, partnership, accessibility, and integration. Part of the strategic focus areas is service delivery. And as I'd mentioned, we're enhancing capacity of reproductive health network to deliver sustainable, comprehensive SRHR services, to include advocacy, and this is strong network to advocate for laws and policies that promote SRHR, And also we work with adolescent and youth engagement, where we increase access to comprehensive SRHR services to young people, including key population. Research and evidence generation, we've been part of convening with the Ministry of Health annual scientific conferences where the stakeholders are brought on table to discuss matters concerning sexual reproductive health. Then of course we also work at movement building, that is a strong, vibrant, locally owned intersectional movement with global allies championing for an enabling environment for sexual reproductive health. So why does self-care matters? According to WHO, is the ability of individuals, families, communities to promote health, prevent disease, and maintain health, and cope with illness with or without a healthcare worker. So self-care does not replace a healthcare worker, but it supplements the already existing healthcare systems. So it empowers people with knowledge and tools to manage their own health, while ensuring self-linkages to professional care when needed. So self-care expands access to essential SRHR services and reduces preventable maternal and neonatal health. So self-care empowers individuals and strengthens system. So the national guideline for self-care adopted by WHO and Kenya, self-care empowers individual in everyday life with complementing the health system. So we are looking at self-awareness, the self-diagnosis, and self-awareness is that the mother or the community, they do have an information regarding the sexual reproductive health. And also self-diagnosis, that they can be able to walk into a pharmacy, they can be able to walk into a nursing home to test themselves without being told by a healthcare provider. And also self-management, self-medication, they can be able to offer themselves treatment. So the conceptual framework for self-care interventions are purely built on accountability and an enabling environment that is supported by access points like homes, communities, and communities, we come along with the community-based strategy where you're working with the CHARs and community health promoters who are able to access that information at the grassroots level. Then you have the pharmacy and the health facilities. So at the core of the key principles is human rights, that an individual must have their rights or should know that they have a right to information, gender equality, ethics, and protection. And that ensures self-care contributes to health and well-being. So the role of midwives, and the role of midwives in self-care starts at the preconception self-care. So you're saying you're educating and counseling in terms of nutrition, family planning, and this is what we were talking about after delivery, that you've already been informed about family planning. That starts at preconception stage. Menstrual health, then support with self-testing, that they're able to access the self-test kits for HIV, they're able to do their breast examination, they're able to do self-test on pregnancy. Then role of midwife is also promoting healthy behaviors, like giving health educations on exercise, deworming, and avoiding alcohol and substance abuse. Then ensuring referral and follow-up. Then the role of midwives in antenatal self-care, and this one we've been doing, is creating awareness in terms of early ANC, encouraging women to do the 8 contact visits, birth preparedness and giving health talks on the danger signs, then guiding the mother on safe use of self-test, the urine, when do they know when it is a danger sign, blood sugar, when do they know they are hyperglycemic and to visit our healthcare facilities. HIV also, do they know how to interpret the test if they take the test from home. Then supporting self-management diet, adherence to hygiene, adherence to ARVs, hygiene, and breast care. Then providing psychological support, that is reducing fear, stigma, and misconception, and also escalating and referring when complications arises. The role of midwives also in self-care goes direct to interpartum and postnatal self-care. So you're looking at educating a mother on signs of labor, when to seek skilled birth respectful maternity care, then guiding on supportive practices on breathing, positioning, hydration, and pain management, then self-delivery practices, escalating the complications early. Postnatally, the role of midwife is the breastfeeding initiation, cord care, hygiene, danger signs, then postpartum FP counseling, ARV adherence, and collecting feedback to improve quality. So why are midwives key? They are frontiers educators, advocates, and trusted companions. They ensure safe care practices and prevent harm, and they bridge the gap between the community and the health system. So they are central to achieving universal health coverage and SDG targets. So RHNK support to midwives is, of course, training and mentoring in SRHR and safe care, advocacy for enabling policies and guidelines, and innovations such as telemedicine, which we run a hotline number that is free and we get to hear from clients, youth-friendly SRHR services, safe care models, and together with MAC and stakeholders, we work to strengthen midwifery and practices. So as RHNK, we recognize and deeply value the indispensable role of midwives. Our network includes many midwives, and some of them are in the room, so they can wave. The many midwives of RHNK who are part of the network. Thank you. And to achieve the universal health coverage and sustainable development goals, we must continue to collaborate with professional associations like MAC, networks like RHNK, the policy makers, and communities alike. So let us stand together to empower midwives, scale up safe care, and build a health system where no mother, no newborn, and no family is left behind. Thank you.
Thank you. Thank you so much, Lynn Kabuka, for that presentation. We could take questions as we await the next presentation. We are waiting for tea. It's not ready yet, so just allow us to take one more presentation probably as we finalize on that. Any questions for Lynn? All right, so looks we don't have a question, or there is one question here.
Thank you, Lee. It's Lucy Ojamon from Busia County. As an RHN advocate or a champion, just to add some input. If you want to be a very good midwife, you should know the anatomy and physiology of the human being first. When you get a client coming for FP, talk about the menstrual cycle. Most of them wanasema ni chemicals. FP methods are chemicals. Teach them about the menstrual cycle. And you should know at your fingertip. Minimize referrals. Any skill that you are not aware, please train on it. When a client comes, particularly reproductive health, the CAC services, incomplete abortions, make sure you know about the cancer screening. You should know all the methods, both natural and artificial. Let the client choose from those methods. I've seen in our register there's cycle of beats. We teach our clients like we don't have enough. So from the ministry, I think, tell us more about that. Most clients also like using the bead, but we are not able to provide because they're supposed to go with a sample. You also have to undergo VCAT training. If you have never done that, the VCAT training, please don't start training or explaining anything about RHNK. I'm about family planning on the client. I think we are aware. For RHNK, if you are a member, you are supposed to undergo the VCAT training, all the methods. When you receive a client, give a comprehensive information and all the services. reduce or minimize referrals. Thank you.
Thank you. Thank you very much for that input. So our next speaker is Dr. Sally Oronje. Dr. Sally Oronje is one of us. We know her very well. She's our National Vice Secretary. She's a lecturer at Masinde Muliro University. And today she's here to take us through one very important area that we have not taken a lot of attention, and this is effectiveness of midwife-led debriefing on prevention of postpartum depression in Western Kenya. Karibu, Dr. Sally.
Thank you, Dr. JJ. I'll go straight to the presentation. This was about effectiveness of midwife-led debriefing on prevention of postpartum depression. As we understand that depression currently is on the rise, and women delivering are not exceptions. And we've not been able to venture so much in regard to what happens after delivery. We normally see the women just deliver, and after delivery, we are happy that the baby is out, but unfortunately, we are not able to see what comes of it all. Because we understand, by the end of it all, when they deliver, there is joy. But what happens then if they experience postpartum depression later on? So this, again, has not been much explored, especially in the African countries, and even the area that the study was being done. But when you look keenly in regard to what follows in terms of postpartum depression, there will be an array of other effects in regard to management, and there's so much in terms of expenditure in regard to management of postpartum depression. But at the same time, that also affects the entire family. So this was very key, because it was important to understand how we can be able to look at, how we can be able to mitigate postpartum depression using the approach of a midwife-led debriefing, which can be a model of care. So we're looking to investigate the effectiveness of midwife-led debriefing on prevention of postpartum depression. So how did we go about this? The research design was it was a quasi-experimental. We had both the control and the intervention side. That was Kakamega as the intervention, and Bungoma County Referral Hospital as a control area. The purpose for this is to be able to see those that went through just a normal standard care, and those that had a structured approach of midwife-led debriefing, that eventually what is the outcome when you follow. We used a standard questionnaire, that is the Edinburgh postpartum depression scale, approved by WHO, that when it is the score is up to 30. So when you do the score and it is above 13, it simply means that it is equivalent to postpartum depression. So those are the ones that we follow to be able to see, using the approach of midwife-led debriefing, to be able to see whether they would come down to below 13, that interpreted that they improved. And if they remained above, that indicated that there was no improvement. So we had an approach of, we looked at the approaches, that is the individual approach and the group approach, and we realized that group approach was more significant, possibly because the discussion led by the midwife, that the others were able to give their own experiences to the other women, and you realize that they also felt like if somebody had the experience of the other one, they feel like they were not the only ones that went through the process. And in the process, they were able to understand from the others how they can go about. And that was also seen from other studies that were done, that the group approach was more effective as compared to individual approach. We also looked at the socio-demographic factors and the obstetric factors, and the key area in terms of obstetric factors was mode of delivery. And in our African setup, and Kenya specifically, is that when a woman goes through cesarean section, it looks like they are not a real woman. So that is one of the things that really affected them in terms of when they go through cesarean section and they feel like they'll go home, the mother-in-law is going to complain. So that affects them psychologically. And even they look before their spouses that they are not real women. So in regard to this, again, midwife-led debriefing was able to help them, especially in regard to cesarean section. That was also seen with other studies that it was more beneficial also in regard to those who went through cesarean section because mainly of the stress that they were passing through. The other socio-demographic factors that supported in terms of looking at the effectiveness of midwife-led debriefing included the age, and more often than not, the ones who are younger needed more information, and therefore this approach was also very important. The key that also came out clearly was the support, the family support, the relative support was very key in terms of enabling them to avert from really getting into postpartum depression to non-depression. And then now we looked at, that was mainly the support, and you can see the support was very significant, and it is also interpreted from other studies that were done. So from this study, midwife-led debriefing was evident based on the significance seen regarding the socio-demographic characteristics. Now, looking at the model, we were able to look at the model in regard to all controlling the other variables to be able to see whether midwife-led debriefing was significant, and based on the p-value of 0.003, that indicated that midwife-led debriefing was significant when other things were left constant. So this also agreed with other studies that was done internationally by the various individuals, that is Martin Comel et al. 2022. Results agree with Abdullah et al. 2020, indicating positive benefits. However, there are also studies that were done by Martin Comez 2022 that disagreed with the findings, possibly because of the geographical area that these individuals were in. So, but with the significance of 0.003, according to this study, then midwife-led debriefing was effective. Now, this was the protocol that is a proposed protocol based on the protocol that were used during the study. And therefore, after the study, following the results and some of the things that needed to be input to ensure that we can be able to look at a protocol where how we can be able to go step by step to ensure that eventually we are able to prevent postpartum depression. And this is a very key proposal. So the proposition is that every midwife is important to understand how to do the debriefing. And so that desires that midwives need to be trained, or healthcare providers within maternity setup need to be trained on how to do midwife-led debriefing. And the first thing that they need to be able to do is to be able to do an assessment to understand the level of postpartum depression. And the cutoff is, if it is 12 and below, that is a person that then can be able to be discharged home and eventually go with family support. If then it is above, equal or above 13, in terms of 13 out of 30, then they are exposed to a group discussion during the postpartum, in the postnatal ward. Then they're exposed to that debriefing as a group, and then from there, because they're going to be discharged home, then we can be able to do an individual follow-up monthly with social support, especially those individuals that were above or equal 13. Then possibly in 3 months later, looking at the study, is that by 3 months, if possibly the midwife-led debriefing has done its effect, then most likely, then most of them will turn into below 13. So from this, a second assessment can be done at 3 months, and if it is above, if it is below 13, then they're discharged home to be able to continue. But if now it is above 13 at 3 months, then that is we need to continue with social support and support regularly at the clinics or MCH clinics, and then that can again be done assessment after 6 months. If at 6 months the client is still above 13, then that will desire that you need to refer this woman for specialist review, and most likely a psychiatric review, based on the fact that the assessment is keen and it is authentic, or its authenticity is very key, that then they can be followed with psychiatric review. So that is the model, the proposed protocol that came out from the study. So in conclusion, midwife-led debriefing group approach was very important for reduction of symptoms of postpartum depression. The effectiveness of midwife-led debriefing was influenced by factors like socio-demographic characteristics, obstetric factors, and even the midwife attitude during care. Midwife-led debriefing, again, intervention was key in reducing the symptoms of postpartum depression, and therefore standard protocol on midwife-led debriefing flow, that is the flow of activities to be proposed to be able to be used, and therefore this can be tested and eventually used in other facilities. Our recommendation is that the county and national governments to implement the midwife-led debriefing to prevent postpartum depression by integrating it into the standard practice of postpartum care. Again, health system to develop and implement policies that will strengthen social support to mothers to prevent postpartum depression. That also includes media to just be able to inform members in terms of even the spouses on how to support the women during delivery. Of course, it starts antenatally during delivery and even post-delivery. The training institutions again need to integrate the proposed protocol on midwife-led debriefing into their curriculum for the purpose of the pre-service to get the information and eventually use it as they get to the clinical area. Further study again can be done to be able to look at the long-term effects of midwife-led debriefing. Thank you and be blessed.
Thank you, thank you. Thank you so much, Dr. Sally, for coming up with a model that we can adopt. I don't know if the study is published. You could share with us the links so that we can familiarize and adopt in our facilities. Thank you so much. So we will break for tea. Tea is served downstairs. And let me request those who have poster presentations to pass by at the scientific desk. And also those from Jacaranda, either you're working or sponsored in Jacaranda, you are welcome to pass by here. Someone has raised their hand. I don't know if it's a question or a comment. So let me start with that.
Thank you, Dr. Sally, for the good work on maternal depression and especially on perinatal mental health component. We know that we have the two tools, PHQ-9 and Return to Normalcy Living Index, but now you are introducing the midwifery debriefing part. From your data, I saw there was an issue of the component, the partnership. Did you dwell into that much? And how was the social support? Then the issue of income, because we know that's one of the components which brings a lot of stress to our women, especially in low and middle income countries. But you have done an awesome job. That is a neglected area, and I look forward to learning from you. Thank you.
One more question, then we will allow you to answer.
Thank you. My name is Dr. Nancy Maingi from Dedan Kimathi University. Thank you, Dr. Sally, for a good presentation on midwifery-led debriefing. Now, I noticed when you were talking about the sample size, you talked about 212. I don't know whether you had taken care of attrition, because when you are presenting the results, I noticed on the control you are reporting about 16 participants, and on the intervention you are talking about 49 participants. So is that really adequate to generalize the findings that you had from this study? Then you talked about following up your clients. I think I saw 6 months. So I'm wondering why 6 months, and do you have any intentions of doing a follow-up? Because sometimes for these longitudinal studies, you need to follow up for a duration of time, probably also to assess whether in future pregnancy they may develop this depression. So what are your future plans for this particular study? Thank you.
Thank you for those questions. I will start with the first one in regard to support. So So let me start with the last one so that I can come upwards. We had a total of 212 that was inclusive of the 10% attrition rate in both sides. And eventually that means we had numbers that were calculated based on the effect size in regard to the intervention site and the non-intervention site. We had a total of 165 in the intervention and the other 40-something in 47 in the non-intervention or the control group. After the assessment, then we realized that it was, we went through the process. However, those who had less than 12 in terms of the score, following the whole process, then we realized that they never turned from non-depression to depression. So therefore, it was left out for analysis, and therefore we focused on the ones that were above 13 that then was going through the every 3-month assessment. And in every that 3 months, there is the second discussion with them in terms of the midwife-led debriefing. And eventually, in regard to, that is 3 months, then the 6th month, it's not another after 6 months. So it is 3 months and then another 3 months. So that means at 3 months and at 6 months. So a total of 6 months. We went up to 9 months, but the difference is that between 6 months and 9 months, there was no difference. So then we, our proposition in terms of the protocol is that it can end at 6 months to be able to determine whether you're going to discharge or you're going to take it for referral purposes. In terms of support, we looked at the various supports, and the key support was the family support. We never, for those ones who are above 13, we engaged the family members in terms of support. But at the beginning, we didn't have any plan to bring out the family members. But upon the time that we realized above 13, then we brought in the family members. Again, in terms of the finances, that was very key, especially we had one particular one, though, that didn't continue with the process, but was early referred because, number one, had a cesarean section, very high depression rates in terms of the levels, then that needed a quick referral for psychiatric review, and therefore we did not want to maintain at that level. But the key thing again is that without finances, women were very depressed, and they really wondered how they can be able to pay up their bills. So that was, again, was very key in terms of, especially the ones that came in and they didn't have someone to visit them. And they are seeing others being visited. It really affected them psychologically. And based on this, the midwife-led debriefing also supported, because the others would be able to speak out their experiences, and therefore there was some light at the end of the tunnel in terms of the others also getting motivated to be able to move to the next step. The recommendation is that a long-term, a study that can be done longer can also be done, and not really longer, because looking at other studies, that was almost the same results, but it can cover a larger area, a larger geographical area, and it can even be like for the whole country, so that we can be able to see whether this can be looked into in terms of the same. But the protocol can also be tested to see whether we can be able to take it again. In the process, we also realized that we need to debrief midwives. Thank you.
Thank you. Thank you very much, Dr. Sally. So that is an area that we can keep discussing over and over. You're welcome for tea. This served downstairs. Then we will come back. Karibuni.
Many disconnected apps, and it's killing team productivity.
Thank you, Mrs. Sally. My COD. My COD. Tell her. Hello. The last. After tea. Hello, Dr. Sally.
Thank you so much. I'd like to start in a minute, please, because I want to make sure that I can share all my thoughts before I have to leave.
Thank you, Nia. We will give you an opportunity. This is Dr. Sally Oronja. I know we've met, the National Vice Secretary, Midwives Association of Kenya.
Thanks, Dr. Sally.
Before you, we have our Director Nursing Services, Kenya, Dr. Winja, who is right with us today. We have our Registrar, Ann Mokuna, with us, and we also have the Minister of Health, and other partners, and more specifically, all members from the country all over, from diversely the 47 counties. We're looking forward to listen to your presentation, and we will allow you to do your introduction, and then you continue with the presentation. Karibu.
Thank you. So will someone tell me when I can start, or?
Hello?
Yes.
You can project your presentation?
I'm just going to be speaking, so it's fine. I don't need a
That's fine.
presentation.
Continue.
So then I'm going to start. So thank you so much for inviting me. It's an honor because, as Dr. Sally mentioned, Mac is a very old friend of mine. So good morning to all our distinguished delegates. I see some very important people in the audience today. Esteemed colleagues, to is not just a celebration of how long you have been doing this, but it is, to me, it's a testament to the passion and the commitment of the midwives in Kenya. So as I mentioned, I work at ICM. I serve at ICM as Humanitarian Engagement and Climate Advisor. And on behalf of ICM, I would like to say that we are very proud to count the Midwives Association of Kenya among our strong and visionary member associations. And over the years, we have seen MAC grow in strength, in credibility, and influence. So MAC is not only advancing the midwifery profession in Kenya, but is also, I think, quite an inspiration for other associations and midwives across the region. So we work closely with MAC, and we really recognize the tremendous potential you hold to strengthen and advocate for midwifery in your country. And in my time that I've spent with you and learned from you, I've seen that your leadership is really shaping the national agenda, and you have been influencing policy. You're giving voice to midwives at different levels of the health system. And so we have a joint vision that every woman, every newborn, and every family is getting the care of a well-supported, well-trained, and an empowered midwife. So coming to the theme of this conference, which is Midwives Collaboration for Resilient Health Systems, I think this comes at a very good time, this theme. So the past years have shown us that health systems can be shaken. They can be shaken by pandemics, as was in COVID. There's climate crisis. We're seeing floods. We're seeing drought. We're seeing disasters. The health systems can be shaken by economic pressures. But in all of this, we have midwives who they remain steadfast and they keep doing their work. And resilience, as I see it, it's not built by one profession or one organization or just one government. It's built when we have collaboration. So that collaboration can be between midwives and nurses, between communities and midwives, between policymakers and communities, and between national associations like MAC and also global movements like ICM. And what we've seen is that when midwives are included in decision making, because as you know, ICM works with midwives associations globally, and when midwives are included in decision making, and when your expertise is informing maternal and newborn health policies, we see that the health system does become stronger. And we also see that when midwives are adequately resourced and respected, communities are becoming healthier, and also there's just an overall growth in the trust in the system. So at ICM, I want to talk a little bit about our global work, that we see midwives as central to achieving global health goals. So that includes the Sustainable Development Goals, which you all know. Studies consistently show that investing in midwives is saving lives. So up to 4.3 million maternal and newborn deaths could be prevented every year if high quality midwifery care was accessible to every woman. And Kenya has made some very remarkable strides, but challenges remain. So there is a shortage of midwives, there is unequal distribution, and sometimes there is limited recognition of scope of practice. And this is where MAC's advocacy is very important. So by raising your collective voice, you're ensuring that midwives are not only present in the system, but they work in the system empowered. So this conference itself, I think, is evidence of MAC's growing influence. So you've created a respected platform for knowledge sharing, for innovation, for professional growth. Here I see all of very important guests. So I see that you're engaging with government, with academia, with partners, and reminding us all that resilient health systems always have to have resilient midwives. So I was talking about MAC and everything that MAC has accomplished. So ICM is very inspired by MAC and the midwives in Kenya and your work in areas such as championing midwifery education, continuous professional development, advocating against harmful practices. You've been exploring digital innovations to bridge maternal and newborn health gaps. You have fostered partnerships beyond the health sector, also into communities. I think MAC has also, I believe, been at the forefront of lots of exploring a lot of life-saving innovations. So your engagement in the emotive trial, which is testing and applying practical solutions for PPH, has placed Kenyan midwives on the global map of maternal health research. You've also been early adopters of new PPH interventions such as heat stable oxytocin, the non-pneumatic anti-shock garments, and improved protocols. And now, I think beyond clinical care, MAC is also raising its voice on climate and health, and recognizing that changing climate is an environmental issue, but it's also a maternal and newborn health issue. So by connecting midwifery with sustainability, you're really shaping a vision of care that is very future focused. And that's why ICM values you as a partner. So in closing, I would like to say to MAC, to all of the midwives, to all the leadership over here, that as you move into the next decade of your journey, I think what you should remember is you should absolutely always lead with courage. So potential of MAC is enormous, not just for Kenya, it's for the African continent, it's for the world. And I think you should always keep advocating for policies that really expand the role of midwives. You should keep investing in evidence-based practice and innovation. You should keep strengthening your partnerships, and because collaboration is always the center of all of it. And to all of the important partners and governments and stakeholders that we have today in the room and listening in, I want to say that you have to invest in midwives, you have to invest in midwives associations, and you have to invest in midwife leaders to invest in the future of Kenya's mothers and newborns. Thank you very much for inviting me, and best of luck for the rest of your conference.
Thank you very much, Nia, for that presentation, and thank you again for committing your time to join us today. Just allow us a few minutes if there is any question to Nia. Any question to Nia?
I think that's it. Thank you so much, Dr. San. Thank you.
Thank you very much, Nia, for that presentation.
I will take my leave now.
Yes.
I look forward to hearing more. Okay, goodbye.
Thank you very much, and God bless you. You can continue with your other activities, and we totally appreciate your presence even as you've left. We will move into Mombasa team. DJ ni pamoja kama iko. We are going to a session that is very important for us. That is going to be the official opening. But before that, DJ nipe moja na unipatie ile nzuri. Watu waweze teremusha chai. DJ unanilet down aje.
Oi mama ko Oluya Oi magana Usebosi Bungoma Kandui Wato Joni.
Sauti ni kidogo sana. Just check it down a bit. I am told that the outside wind is hotter, and our expectation is that the AC is on. We are supposed to close the windows so that we can have a cool environment. That is the advice that was given to me by the management. If we open the windows, then we will not feel the coolness of the room. So if we can close the windows and allow the AC to take its effect, then we will have a cool environment within the room. Because if we do open, that means we are mixing up, and eventually we will not succeed in getting the cool environment. Yes, so kindly, if you're next to a window, we can test it. If you're next to a window, kindly close the window and let's allow the AC to take its effect. Then we can ensure that we are able to get the AC. Chairs are being brought for those of us who have no chairs behind. Chairs are being brought over so that everyone can have an opportunity to sit and be able to follow the proceedings, even as we continue with the sessions. Tafadhali. Thank you very much. Good morning, everyone. Good morning. Can we be upstanding for the national anthem? Can we be upstanding for the national anthem? Just a minute, I'll recognize. DJ.
Mungu nguvu yetu, ilete baraka kwetu, lakini wendao na mlinzi, na tukae na udugu, amani na uhuru, raha tupate na mustawi. Mungu twaomba uilinde Jumuiya Afrika Mashariki, tuwezeshe kuishi kwa amani, tutimize na malengo yetu. Jumuiya yetu sote tuilinde, tuwajibike, tuimarike, umoja wetu ni nguzo yetu, idumu jumuiya yetu.
Thank you. Thank you very much. You can have a seat. I call upon Jacinta Angote to come over here. And one representative of the Muslim community for a prayer. Kindly come over here. One representative from the Muslim community. A volunteer, I was told to ask for a volunteer. A volunteer. For a prayer.
Alhamdulillah Rabbil Alamin. Okay, we are praying. Al-Fatiha. Amin. Bismillahirrahmanirrahim. Alhamdulillah Rabbil Alamin. Ar-Rahmanir-Rahim. Maliki yawmiddin. Alhamdulillah Rabbil Alamin. Assalatu wassalamu ala ashrafil anbiya wal mursalin. Rabbana taqabbal minna innaka antas samiul alim wa tub alaina maulana innaka antat tawwabur rahim. Rabbi zidna ilma warzuqna fahma. Rabbi zidna ilma warzuqna fahma. Allahumma arhaqna haqqa warzuqna ittibaa wa arzuqna batila batila warzuqna tinaba. Ya Rabbi, Mwenyezi Mungu tujalie afya njema, tupatie maisha marefu. Bifadli subhana rabbika anta masifun wa salamu ala mursalin alhamdulillah rabbil alamin. Amen. Amen. Amen.
Let us pray in the name of the Father, the Son, the Holy Spirit. Amen. God our Father, we come to you this morning. We are grateful, Father, for your love. We thank you, Father, for your care. We thank you, Father, for your protection. Father, as midwives and friends of midwives, we come to you thanking even for the journey mercies that you granted us up to this place, oh my Father. Lord, even as we want to start our opening ceremony, we want to invite you in our midst, that Father, you will fill us with your love, that Father, you will fill us with your care, that Father, you will guide us through this ceremony, and in the end, all glory and honor comes back to you. Father, we even thank you for our guests this afternoon. We thank you for every midwife that is here and all our invited guests, oh my Father. As we start, we ask that you send your Holy Spirit to lead us, and in the end, all glory and honor comes back to you. For this I pray, believing and trusting in the name of Jesus Christ.
Amen. Thank you. Thank you. I want to call upon Amina to bring forward the little theater for an entertainment.
Hamjambo. Tunawakaribisha katika kipindi cha entertainment na kitaongozwa na Little Theatre Club ambayo yatoka hapa Mombasa, Mbaraki. Karibu Little Theatre. Wataanza na skit, wamalize na traditional dance. Karibuni.
Na amejikaza kweli kweli. Wewe watatu na unalia hivi. Hebu pita huku, enda huku. We, baba, unanifundisha kazi yangu. Hawezi kutembea huyu? Si unaweza kutembea mama? Aya, pita hivi. Enda hivi mami. Baba. Kama ungekuwa unataka kusaidia huyu mama ungemsaidia nyumbani kuzaa. Mimi najua kazi yangu, najua ni unasikia? Si kwenda shule bure.
Sawa.
Nguo za mtoto ziko wapi?
Nimezisahau nyumbani.
Sasa tumfunike magazeti. Tumfunike na maganda inaitwa aje? Mitawi ya migomba ama tumfunike na kuti za mnazi?
Samani nachukua.
Unajua nyinyi watu mmekuwa mkitushangaza sana. Wamama mnakaa nyumbani hadi labor pain inazidi naongezeka, mtoto wako almost kutoka ndio mnamleta hospitali sababu tu ya mwenyewe syndrome, si ndio? Yaani mnangoja paka mabwana zenu watoke makazini ndio wakuja walete hospitali. Wewe ndio ulibeba mimba? Si ni yeye? Kwa nini hakukuja hospitali mapema?
Tusaidie nasi, tusaidie.
Sikiliza. Mami, nimekwambia ingia huko labor. Ninakuja kukuhudumia. Na baba, nenda umletee nguo za mtoto tutamvalisha.
Wait. Breathe in. Breathe out. Breathe in. Breathe out. See. In the beginning there was word, and the word was spoken. I'm in a quagmire, devastated, busted. See. I'm silenced. I'm silenced by the nurse. Tumekaribishwa na maneno badala kukaribishwa na chai. Itabidi tumetii. See. We came for birth. We came for birth, but we met a nurse. A nurse who delivers insults faster than delivering babies. No empathy. No empathy for the girls, mothers and daddies. See, it's so sad. Najua huyu mama hakuwa footballer, lakini ni kwa sababu ya uwezo wa Mungu ndio sababu ako na ball. Say, my friend is crying for help, but his wife is crying for breath. So wait, breathe out, breathe in, breathe out. See, I feel this hospital is in darkness, crisis. Ama acha niseme tu, the world is in a massacre. Sijui Manase washamsahau Mungu wa Yakobo, Petro na Isaka. Sijui sababu ni yao, ama sijui sababu ni kwa sababu hakuna vifaa za anatini. Sijui na siwezi jua. Say, time pushes harder. Time pushes harder than contractions. We're in this hospital with no help. Or maybe this is help, but we don't know. Say, but we hope this mother will give birth in a nice way. Tunaomba tu mambo ikue barabara, kwa sababu kwa kwenye tumetoka si nzuri barabara. So breathe in, breathe out.
We mami, hebu nimekwambia twende huku haraka. We hebu nenda mliletee nguo haraka haraka nisaidie mama kujifungua. Mnasikia?
Sawa dokta.
Yaani kina mama mmechagua time ya kujifungua ni saa 7 za usiku. Hakuna time nyingine mnataka kujifungua. Pita huku.
Kaze.
Hizi watu watapumzika ama tutaingia tena. Okay, mke wako amejifungua mtoto wa kiume.
Asante sana.
Ni sawa, lakini tumempoteza. Wacha niende nikakuchukulie discharge letter, utaenda kwa reception, atakueleza zaidi.
Dokta, mtoto wangu amefariki.
I hope nimeongea Kiswahili na pole sana kwa aliyokukuta. Sawa, nisubiri hapo.
Dokta, samahani. Mtoto wangu amefariki.
Unajua sasa mimi sijui lugha yako. At least ningeongea ukanielewa. Nimeongea Kiswahili nikiamini kuwa unaelewa. Naenda kukuchukulia discharge letter, nikuletee uende kwa reception akueleze ni jinsi gani utafanya. Unasikia? I have so many patients to attend.
This is not setting me right. Mtoto wangu, tegemeo langu, watu watanionaje mimi zaidi? Nimekuwa nikichekwa kwamba siwezi pata mtoto wa kiume. Leo hii niko karibu kumpokea mtoto wangu, lakini sijamweka hata mikononi mwangu.
Yes, habari? Nini kinaendelea hapa?
Mwana mke wangu wako wapi? Mke wangu wako wapi dokta?
Hemu daktari, tuelezee kuna nini hapa?
Amemleta mke wake kujifungua, but unfortunately tumepoteza mtoto.
Mmepoteza mtoto?
Yes.
Amepotea kivipi?
But sio fault yangu. Ni mara ngapi tumeambia kina mama wakipata labor pains wa kuja hospitali mapema tuwasaidie kujifungua. But mtu anakaa nyumbani hadi mtoto ako almost kutoka anamleta hospitalini. Sisi kama manasi tufanye nini? Kwani nyinyi watu hamuoni side yetu? Unajua nimeenda shift mara ngapi kwa wiki hii wiki? We are only 2 in this dispensary. Mimi niko maternity kusaidia kina mama kujifungua. The other person anapeleka mama wengine ward. Mnataka sisi tufanye nini? Licha ya hayo yote tunakosa mpaka ambulance ya referral kwa hii dispensary yetu. We have to wait almost hours ndio kina mama wapate referral za kwenda kujifungua hospitali zingine kubwa. Tunakosa hata resources kwa hospitali. We can't even have gloves za kuni protect mimi na mgonjwa wangu. Una expect sisi tufanye kazi aje? We have families zenye zinatuhitaji nyumbani, but because we are only 2 we have to stay in the hospital. We are wives, we are mothers, we need to take care of our husbands, we need to take care of our children. But because of our calling of us being doctors and nurses, lazima tuhudumie watu hapa hospitalini. Do you see that? You don't. All blames, all claims zinakuja kwa sisi manurses. Umezunguka mkaangalia hospitali venye inakaa.
Okay, listen first, okay? I know mko kwenye harsh conditions, okay? Ndio maana sisi kama Midwife Association of Kenya tunajihusisha na wakunga, okay? Sasa sisi tumekuja kutembelea hiyo hospitali tuangalie hii side ya maternity inaendelea vipi.
Very bad.
Tumesikia kilio chako nas, okay? Na sasa sisi tunakualika kwenye tuna kongamano lenye litafanyika hapa Sairo Hotel kuanzia tarehe 10, 11 na 12 ili wewe uje kupata elimu zaidi ya kwamba ni jinsi gani tutaweza kusaidia kina mama wajifungue kwa njia salama.
Pia kuongezea tutapatia nurses wa kutosha, tuko in partnership na the county government. Pia tutahakikisha kwamba zahanati hii itakuwa na resources ambazo mnahitaji kama wakunga wa kuzalisha watu.
I hope we are going to act fast kwa sababu hapa hatuna resources za kutosha. And you know this area of ours kina mama wanajifungua kila kukicha.
Yawa mama, tumesikia sisi kama Midwife Association of Angoa.
Yeah. Midwife Association of Kenya.
Tumesikia. Sasa mama, pole sana kwa msiba uliotendeka katika zahanati hii, lakini hakikisha kwamba sisi tutakuja na resources. In fact, tumezileta ziko hapo nje.
Sasa mimi kuatendia mkutano, do I need to be registered ama tu niende tu nijiingililie?
You have to be registered. Okay? Ukitaka kuwa katika association yetu lazima uregister, okay?
Okay. I hope you Mark and the county government will bring change. Ni sawa, asante.
Okay, thank you so much.
Thank you.
Tupatie nani? Tupatie moja bebe. Kwa meza. Hapo kwa meza.
Asante. Thank you. Thank you very much. Can we give them a round of applause? Tuwapatie makofi tafadhali. Makofi tena, makofi tena. Asante sana. Thank you so much for that wonderful presentation. We are happy that we came back to Mombasa so that we can get a nice presentation from the Little Theatre Club. So thank you very much for that presentation. Allow me to now hand over to Madam Eunice Atali. Thank you.
Thank you so much. Mmefurahia entertainment? Thank you very much. Team Mombasa dancers, asante sana. Thank you so much for that wonderful dance. And also the ones who did a skit, asanteni sana for demonstration of respectful maternity care. That was very well demonstrated. So I take this opportunity as Midwives Association of Kenya to say again, thank you so much for coming on the 10th Annual Scientific Conference, which is themed Midwives Collaborating for Resilient Health Systems. And I saw the collaboration very well within the healthcare system in terms of resilient healthcare system. So on behalf of Midwives Association of Kenya, I wish to welcome Mombasa team to welcome us in their home. Situma. Tarabu.
Hamjambo nyote. As we wait for him to give us ya Mombasa. Wow. So you can dance where you are. You don't go like 2 minutes. This dancing is welcome you to Mombasa. Mombasa twapenda bango, and that is bango. Bango is a kind of music ile unaji swing pole pole tu.
Yataka ujue yembo hizi bango ni
Badae. Otherwise, my name's Caroline Situma. I'm the chair, Mombasa branch. I take this opportunity to welcome you. Karibuni sana. Mombasa, we are happy for the 3rd time to host you here. Karibuni. Feel free. Baadahi, there is a bahari pale, muenjoy. There are so many things in Mombasa. Karibuni. Thank you.
Asante sana. We are feeling now at home and we love the weather. Sindio? At least the weather is much better than previously because it's balanced between warm and cold. So I wish to welcome the Vice Chair for Midwives Association of Kenya to be able to give remarks on behalf of the chair who is not able to come to this conference today because of an eventuality. Catherine?
Thank you so much, Eunice. Yeah, thank you so much, Eunice and Dr. Sally. Again, I want to appreciate Mombasa team for allowing us come again to Mombasa. Good afternoon, midwives. Thank you. I want to welcome you to this 10th Annual Scientific Conference. But before I can read Dr. Tekla's message, I would want to recognize the presence of all midwives in the house. We have midwives who work together, who struggled from the beginning to ensure that we have this association. The old midwives in the house, wanaweza kusimama? Can you stand, please? I have seen Nerea. We want to recognize her. Let us appreciate her. Thank you for coming. Again, I want to recognize the presence of midwives who are attending the MAK conference for the first time. Those who are attending our conference for the first time, please, can you stand? Thank you. Let us appreciate. We appreciate you. We have midwives from Busia, Tana River, all over who are attending this conference for the first time. We want to know how we have come in. I know Sally in the morning, she took us through the presentation from every county. And today I want to start from the farthest county. Those who have come from Busia County. Busia. Let us appreciate Team Busia. Bungoma County. Bungoma, thank you. Those from Bungoma, Asanteni. Trans Nzoia County. Anybody from Trans Nzoia? Thank you for coming. Anybody from Kakamega County? Asante, Kakamega County. Vihiga County? Vihiga, anybody from Vihiga County? Kisumu County. Thank you, Team Kisumu. Nakuru County. Thank you, Team Nakuru. Narok. Anybody from Narok? Thank you. Let us appreciate them. Kericho County. Anybody from Kericho County? Thank you. It's the first time we are getting somebody from Kericho. Kajiado County. Thank you, Team Kajiado. Bomet. Thank you, Team Bomet County. Kisii County. Wow, thank you. Let us appreciate Team Kisii. This is the first time coming, yeah? Migori County. Homa Bay County. Thank you, Team Homa Bay. Nyamira. Anybody from Nyamira County? Laikipia County? Baringo. Thank you. Nandi County. Elgeyo Marakwet County. Uasin Gishu. Thank you, Team Uasin Gishu. Samburu County. West Pokot. Kirinyaga. Thank you. Let us appreciate Team Kirinyaga. Turkana County. Kiambu County. Thank you. Murang'a County. Nyeri County. Thank you, Team Nyeri. We appreciate you. Nyandarua County. Makueni County. Thank you, thank you, thank you, Team Makueni, Machakos. Let us appreciate Machakos. Kitui County. Kitui, Team Kitui. Thank you. Embu County. Asanteni. Tharaka Nithi County. Meru County. Thank you Team Meru. Isiolo. Marsabit. Mandera. Wajir. Taita Taveta. Thank you, Taita Taveta team. Garissa. Thank you. Let us appreciate Team Garissa. Lamu County. Thank you, Team Lamu. Tana River. Kilifi County. Thank you, Team Kilifi. Kwale County. Thank you so much. And lastly, County 001. Thank you so much for coming. I'm calling out all these counties because I know in the past 1 year we have held webinars in basically all these counties we have called. So thank you so much for those who have managed to attend this conference. I want to recognize again the presence of all our RH coordinators, county RH coordinators, reproductive health coordinators in the house from our counties. Please, can you stand up? Thank you. Those are the makers of the midwives in every county. Thank you so much for coming. We want to appreciate you. We also have our county directors, nursing services. Those in the house, please, can you stand up? We appreciate you. Those are the leaders in our various counties. We appreciate you for coming. We have our institution, our learning institutions. Anybody from our learning institutions and KMTCs, members from our learning institutions, the universities, Kenyatta. Thank you for coming. Thank you so much. I want to read the speech from our chair before I welcome the remaining teams so that they can be able to greet us. On behalf of our chair, Midwives Association, that is Dr. Tekla Ngotier. She's unable to join us today because of unavoidable circumstances, but I know she is with us in spirit. Greetings from our chair. Now, this is her statement. Distinguished delegates, esteemed colleagues, and valued partners, on behalf of the Midwives Association of Kenya, it is my honor to welcome you to our 10th annual scientific conference here in the coastal city of Mombasa. We are grateful you have joined us from far and near to mark this important milestone. Our theme, Midwives Collaborating for Resilient Health System, reminds us that the challenges facing healthcare today, whether resource limitation or global crisis, cannot be faced alone.
Resilience demands partnership, innovation, and courage to re-image the care. As midwives, we are trusted at the most critical moments of life and committed to equity in access to care through collaboration with governments, educators, researchers, and partners. We can transform outcomes and strengthen the foundation of our health systems. In the days ahead, let us share knowledge, explore innovations, and commit to actions that will ensure healthier mothers and newborns, stronger families, and more resilient communities. As we celebrate 10 years of scientific exchange, may this gathering inspire us to continue working hand in hand for the healthier Kenyan and stronger midwifery movement. Karibuni nyote, Dr. Tekla Ngotier, Chairperson, Midwives Association of Kenya. In addition to that, I want to say that Midwives Association of Kenya represents more than 1,200 registered midwives across several counties in our nation. We were established in alignment with the Kenya Devolution Framework to advance midwifery. And over the years, we have built an identity rooted in solidarity with mothers, respect, dignity, and best-class care. This identity is not only about who we are as midwives, but the role we play in shaping the resilience of our health systems. We know as midwives, we are shaping our health systems each and every day. Here we recognize the vital role of the Ministry of Health and the Nursing Council of Kenya. Their leadership in placement, deployment, and policy is essential for creating an enabling environment where midwives can thrive. Together, we must push for stronger frameworks that ensure midwives are not only deployed effectively, but also recognized for their unique contribution to the maternal and newborn health. This year, we have so many institutes that are empowering midwives, and as MAK, we are committed to strengthen midwives' clinical capacity and leadership, and we also uphold the highest standards of integrity and professionalism, and we drive change through policy advocacy. Every day, we work to ensure that midwives are recognized and are empowered to deliver quality care and to be represented in decision-making spaces where health policies are shaped. Let us live here with renewed determination to advance midwifery, to secure its rightful place within our health systems, and to continue building an identity that inspires respect, recognition, pride in our profession. This year, when we started our campaign, we all talked about hashtag. And every one of us as a midwife, we need to say as a midwife, hashtag, what it takes a midwife to do. Everyone has something to do, a role to play as a midwife. And I'm saying, hashtag, it takes a midwife to collaborate for resilient health system. Thank you so much, and God bless you. I want to take this time to welcome first, we had a scientific conference that put together this conference, led by Dr. Sally Oronje and team. I want to welcome them to stand. Scientific team,
Thank you. Allow us to, I don't know whether you can see us this way. Watu wataki kuangalia. Kindly come over here. I am able shortly. The team that is ahead of us, the scientific team, these are the members that have been able to enable us get all the papers that shall be presented all the way from abstract presentation, review, and finally that you are accepted to be able to present your paper. So my name is Dr. Sally Oronje. I am in charge of the scientific team. Thank you.
Good afternoon, everybody. My name is Lame Kotieno. I'm part of the scientific team. Good afternoon, team. My name is Lame Kotieno. I'm privileged to be part of the scientific team for now a better part of the years that I've been in this association. I'm a registered nurse, I'm a midwife, and I'm a BSN, yeah. So currently I work with Metropolitan Hospital. Thank you.
Mpigie makofi jamii. Good afternoon.
Good afternoon.
My name is Amolo Fidel. I'm a BSN from the University of Nairobi. I'm a nurse intern, currently doing my internship at Mama Lucy. And most importantly, I'm a member of the scientific committee.
Good afternoon. My name is Dr. Caroline Kerubo from JQuat and a member of the scientific committee. Thank you.
Good afternoon. My name is Joyce Chebet, a lecturer at Aga Khan University, member Nairobi MK branch. Thank you.
Good afternoon, team. Monica Mnyendo is my name, working in Mombasa County, Likoni Sub-County Hospital. I'm a passionate midwife and a member of Midwifery Association of Kenya, Mombasa branch, as the assistant chair. Thank you.
Good afternoon. I wish to invite other members of scientific committee that I can see seated comfortably. Dr. Laura Wausi, kindly come. Remember, hashtag it takes a midwife to collaborate. So we have a doctor on board in the scientific committee. We have students, we have interns. So kindly, please, Dr. Laura Wausi. Wausi from Japiego. Yeah, thank you so much.
Good afternoon, midwives. It's a pleasure to be here with you today. My name is Dr. Laura Oyengo. I work at UNICEF Kenya Country Office as the maternal newborn health specialist. Thank you.
So Dr. Laura has been supporting us in the scientific committee as well, and also has supported in program development and the food you are eating here as well, plus many other things. So thank you so much. So my name is Eunice Atsali. I'm the National Secretary for Midwives Association of Kenya. And I wish that all of you can go on your Twitter right now and just go on our midwives. Kindly make sure you tag Midwives Association of Kenya on your LinkedIn. It takes a midwife to collaborate. Thank you so much.
Thank you. That is a specialty in terms of midwife because she's the lead person in advocacy, and that is why she brings about the message. So again, I work at Masinde Muliro of Science and Technology. Thank you and be blessed. Thank you.
Let us appreciate the scientific team for the good work they have done. I want to welcome the planning committee. All that you see happening here today, we had a planning team led by Caro and team. I would wish that they could stand up, please. If you see anything good, That is the team. Welcome. Just introduction.
Good afternoon once again. This is the planning committee of Mombasa. I'm telling you, it wasn't easy. We've been struggling up and about with the support of the national team, but we are happy we made it the way it is. As I've said, I'm Caroline Situma, the chairperson. I won't talk much.
Once again, I remain to be Monica Mnyendo. I am the assistant chair. Karibuni.
Good afternoon. My name is Amina Ibrahim. I'm the regional coordinator for Coast Province. I was part of the planning team, Kitengo cha resource mobilization.
Afternoon. My name is Linda Karea. I was a member of the planning committee. I'm the treasurer Mombasa. Thank you.
Ahlan wa sahlan wa marhaba. Karibuni Mombasa. Kwa majina ni Idel Queen. Idel Queen Akoth Olunya. My Rivati name is Shamsa for my Muslim brothers and sisters. I'm the Secretary General of Mombasa County, currently in Nairobi, undertaking my higher diploma in neonatal intensive care unit. I would wish to welcome you in Mombasa. Kama nilivyosema, kosa uchekwe, na nimeona hamjataka kuchekwa. Kwa hivyo karibuni na mjisikie mko nyumbani. I was part of the planning committee, organizing entertainment and photography. Welcome all.
Hamjambo. Mimi naitwa Fatuma Ali Ngare. Mimi ni mkunga. Nafanya kazi katika halmashauri ya bandari ya Kenya. That is Kenya Ports Authority. Nimekuwa pia kwenye treni. Ati pesa. Ni maombi. Wacha zishuke. So nimekuwa kwenye hiyo organizing committee. Kitengo cha kutumbuiza, yani entertainment. Mimi na Edel Queen ndio tumeleta hao Little Theatre walio watumbuiza. Kwa hivyo tunafurahi kuwa nanyi. Karibuni Mombasa jamani, murelax, mujienjoy.
Midwives hoye. Midwives hoye. Basi nami kwa majina ni Emily Mwaringa. Midwife aliyestaafu lakini very strong. Karibuni Mombasa. Hii ni timu ambayo nimekuwa nimelead for the last 15 years as a midwife, as the county nursing officer. I relinquish power to Dora. She's seated in front there. She's now taking over from me. Otherwise, I've been the patron of this MAC Mombasa branch, and I'm proud to say MAC was born and brought up from Mombasa. That's why you keep coming back. Karibuni sana. Asante. Thank you.
Thank you. Thank you so much. Let us appreciate that team for the good work they have done so far. We have our IBC chair. Please don't bring your team members. Just say hi because you will have a task later on in this conference. We want to acknowledge your presence. The chair, elections. Thank you. He may not be in, but he's around. We have partners who have been supporting us through since we started plans, since we even started this association. I want to appreciate all the partners in the house. Anybody from UNFPA, AMREF, NFPA, AMREF. Thank you. Let us appreciate the team. Anybody from AMREF? Okay. Ferrin Pharmaceuticals. AMREF. AMREF, thank you so much. Ferrin. UNICEF. I've seen Dr. Laura. Thank you so much. Chai, we were with them yesterday. I don't know whether they are here today. Thank you so much. We have Center for Public Health Development. Thank you. Let us appreciate them. ACAF. Anybody from ACAF? Thank you. We appreciate you. RHN, okay. Thank you. Luala Community Alliance. Thank you, Japaigo. White Ribbon Alliance, anybody in the house? DKT, they are out there. I don't know, Aga Khan University? Thank you, they are down there having a booth. If you get time, we can be able to pass there. And our regulator, Nursing Council of Kenya. She's here. Thank you so much. So let us appreciate all our partners. Those have mentioned and those have not mentioned, we want to appreciate you so much as partnering with the Midwives Association of Kenya. I want to take this time to welcome the NEO National Office. MK, please step forward. Yes, go ahead.
Good afternoon, everyone. I think I've said my name 100 times. My name is Dr. Sally Oronje for the National Executive Office. I hold the office of the National Vice Secretary in charge of CPD. That is why you saw me many times during the webinars. That is the learning for midwives across the country, and again in charge of scientific paper presentation. And that is why you also saw me in the scientific team. Thank you and be blessed.
Good afternoon. I've said my name so many times today until I feel shame on me. My name is Eunice Atsali, and I'm the National Secretary, Midwives Association of Kenya. At the same time, my daily bread comes from Kenyatta University, where I teach nursing and midwifery. In MAC, I'm in charge of advocacy and, of course, member mobilization and partner engagements. So those have been my responsibilities. And, of course, supporting the CPD. Thank you so much.
Good afternoon, everyone. I know I've interacted with some of you at the registration. My name is Jen Baluka. I'm the National Treasurer for Midwives Association of Kenya. I take this opportunity to welcome each one of you. Thank you so much. I deal with money. Money is not easy to deal with because we have to uphold the integrity for the association. Thank you so much.
Thank you so much. And my name is Catherine Shienji. I'm the Vice Chair, Midwives Association of Kenya. I'm in charge of leadership and governance of this association. I've been in charge for the past 3 years. So thank you so much. That is the National Office for the Midwives Association of Kenya. I want to, in absence, we have our chair, Dr. Tekla Ngotier, had offered her apology. She's not with us today. I want to take this time to welcome our partner associations that are in the house. We have the president, KPNA, so that he can greet us. If we have anybody from the union, Nurses and Midwives Union, who is in the house and we are not able to see him. Okay, thank you. So I want to welcome our president, Kenya Progressive Nurses Association. Welcome.
Thank you so much. Thank you so much, Madam Chair, for the opportunity you have given us. Itifaki zote zikizingatiwa, ningelipenda kuwasalimu nyote hamjambo. Kiswahili ni kigumu ama niko sawa? Nataka kuchukua muda mfupi. Let me revert to English. I just want to bring greetings from KPNA. We had a meeting yesterday in Nairobi, and the National Secretary and Treasurer and the committee have sent greetings to this Midwives Association of Kenya. Do you receive the greetings? As you have been told, my name is Michael Nyongesa. I am the current president for Kenya Progressive Nurses Association. As you may be aware, we have been working collaboratively with MAK, because I've been attending or sending my people to come and be part of this journey. And as the national chair has said, the president of MAC has said, is that alone, as midwives, you can't make. We must collaborate. And that's why KPNA has the same clarion call that collaboration is the way to go. And that's why when MAK has a conference and we have a conference, we collaborate in many, many things. So we appreciate the collaboration we have between KPNA and MAK. I am happy also to meet you guys. I know we are acquaintances, we know each other, to most of you. And when we meet in such a place, it actually makes me happy. And I appreciate this conference of MAK. It has come at the right time and with the right theme. For us, we stand for harmony as KPNA. Harmony in nursing as the professional cure. And if we cannot sit on the same table, if we cannot collaborate, if we cannot speak, it means there's no harmony. But we are in good terms and happy to collaborate with MAK. A few things I want to raise now that the DNS is here. One is I was a member, and Tekla was a member of the TWG that prepared career progression guidelines for nurses in this country. Sorry, nurses and midwives in this country. And after we had prepared this, of course, COG was on board. The same document was taken to public service and it was approved for implementation in collaboration with the COG. But today, I know you have heard and you have seen whatever is coming out in terms of going back to the drawing board in terms of career progression guidelines. It is a mischief. It is not right. It is politically motivated. And it's a way to deny healthcare workers an opportunity to be able to be appreciated in terms of earnings based on the work and experience they carry along. I know as nursing fraternity, nursing and midwifery fraternity, we are not happy when things go that direction. And so the DNS was the lead person for TWG, and she's here. I am happy she's here. I know that she's a workaholic, and in this matter, I think we need to get some direction on what we are doing to ensure this is able to happen. We are also following and trying to see what we can do. But as the DNS, I think she has a better opportunity to be able to inform us on how else we can go, because we followed the right procedure of doing career progression guidelines. They were approved and they were supposed to be implemented. Number two, I wish to say that Madam DNS, you are a witness on issues that are going around in terms of UHC nurses, UHC healthcare workers. We are not impressed by, this is one country, whether counties or national government. When the ball is being thrown to national government, to counties, to national government, to counties. These nurses who are working under UHC, if they were not there, who would be doing what they are doing? Of course, there would be nobody. And that's why they were hired. What is the challenge? These are our children. These are our sisters. These are our brothers. These are our neighbors. The services they are carrying along in this country, these services is required. In any case, even with their presence, we have still a big shortage. People are getting burnouts. People are getting worked out because of the amount of work they are carrying. But now it has become a game of COG and national government. Something needs to be done because I don't have to call it, but it's openly and blatantly wrong for us to throw our children left and right, and yet what they are doing needs to be done, and equal work must attract equal pay. Why would they keep pushing us left and right when it's important for them to implement the issues that are required to hire these nurses on permanent? I know even in the hospitals with UAG staff, Madam DNS, I work in a hospital, and what's going on, for us to be able to meet the requirements, we are even hiring locum nurses. Because we have a shortage. Why don't we absorb these ones? Then lobby for absorbing others so that we have a healthcare human resource that is able to be responsive, that is able to meet the requirements of Wanjiku and offer quality care. The issues of internship, of course, they have gone quiet. Round-table discussions, Madam DNS, are always the best way to handle issues. As nurses, of course, we are not happy. We are not happy the way some of us have been handled just because of internship issues. So something needs to be done. And nobody's fighting. We are only asking for our right. That when somebody stands to speak, let them identify the problem, and we don't solve problems by sweeping some people under the bus. It doesn't work. It doesn't add value. And so this needs to be looked at because it's important. But DNS, I know you are aware that without mentioning, the staff shortages are abiding. I'm even happy that some of these nurses, midwives who are seated here, may have paid somebody to work for them in the institutions for them to attend this conference because of the shortages that we have. But out of all these shortages, the Ministry of Health, Madam DNS, seems to look down on nurses. Even when Dr. Mangaki was saying that nurses are key, yeah, publicly she's saying we are key. But when it goes to the boardroom, we are not key. What is the problem? If they want a conference where we can sit and discuss, like the teachers went to State House, we, nurse leaders, we are ready to have such a conference and address some of these issues. No, not like when you sit down and you want just to do things the way you feel, and people are suffering out here as nurses. It takes a midwife to collaborate. That's a good hashtag, and I am very happy, Madam DNS. When I move to the hashtag, it means the three issues I've mentioned are adequately presented And kindly, if you find some time, you can inform us on how far the kind of things they are going. Let me tell you just one or two things that we are doing. We, of course, all of us wish to do issues of BLS, of SELS and such. And we have been having these issues in Nairobi. But as KPNA, we have devolved BLS and SELS. Wherever you are, even if it's Mombasa County, and you have a minimum of 5 people who want to train for BLS and SELS, the training will be brought to Mombasa. So that that nurse will come for the training just like she has been coming on duty. Instead of fare to Nairobi, housing, and food, we have said that we devolve BLS and ACLS to come to where nurses and midwives are, for them to be able to access this training with ease and cheaply. So ACLS and BLS, that's what we are doing. We also have NCLEX as a training school, KPNA, and we are going to do it online to train as many nurses as possible. So if you are willing, in collaboration with the leadership of MAC, we can be able to work out, it's called the implementation framework, where we can bring you on board and have this training at ease and from where you are, so that you are not spending more money in the current economy, so that you are not spending more money to travel to Nairobi and to have housing and to have food. Stay in your house and be able to train. Having said that, I wish to invite you also in our conference that is coming in November, on 18th to 20th of November in Kisii. Kindly feel free to attend, because when I'm here, I'm also very, very free. Thank you so much for listening to me. We look forward to work together. Thank you.
Thank you so much, President KPNA, for attending this conference. We want to appreciate you so much and recognize your presence. I want to take this time to welcome our Registrar, Nursing Council, Dr. Anne. Welcome.
In Jesus' name. Thank you very much. I want to recognize all the leaders of different groups and forums at different levels that we have in the house, all the partners, my colleagues, friends, and all of us that on a day-to-day basis, we work towards enhancing maternal and newborn health. Ladies and gentlemen, good afternoon. I bring greetings and well wishes from the Nursing Council of Kenya family, guided by our chair, Dr. Marim. Mmepokea salamu? Asante sana. Najaribu kidogo. Rafiki yangu hapa aniarifu ya kwamba hata wenyeji wa Mombasa Kiswahili bado ni ngumu. Kama umetoka bara, basi Kiswahili ni bara. So let me stick to English. It is an honor for me to join this forum and to join with my colleagues as we take off a moment from our routine work to reflect on the work that we do on a day-to-day basis, to learn from each other, to grow, to network, and to enhance collaboration. And as we speak about networking, najua ya kwamba ushasalimia mwenzako ambaye amekaa karibu na wewe, unajua jina yake na unajua mahali ametoka, umechukua namba yake ya simu. Imefanyika? Asante sana. If you have not picked the contact, networking started in the morning. So make sure that you network because we all need each other. And we are here so that we can form connections that can help us and our clients and the societies and the communities we serve on a day-to-day basis. From the skit that we observed here a few moments ago, it came out evidently the importance and the critical role that a midwife plays. In the entire scenario, we saw that the midwife was the only healthcare provider that mother came into contact with. And this happens perhaps more than 90% of the times that mothers come to the health system to seek for care. And so that speaks about the critical role that we play, but it also speaks of the responsibility and the level of accountability that as midwives we are also expected and anticipated to provide. And I want to thank you all because as we struggle with the different challenges in our health systems, I know that the midwives put forth the best foot to be able to provide care and to meet the expectations of the clients that we meet on a day-to-day basis. Today, the healthcare system is challenging in more than, it is more challenging than it was yesterday. With every client expecting, and with us as healthcare providers expected to look and to take every client not as a care seeker, but from the perspective of a customer. And some of the expectations may not cost money. I know that in the midst of the challenging environment, for example, in the skit that we observed, perhaps the midwife would have reserved energy, more energy by treating the family well. And the collaboration that would have been formed, even when the outcomes are not as expected, helps the family to identify with the care process and to appreciate that the provider indeed did what they could do within the context that they were operating on. And therefore, as we leave this conference, as we continue interacting, let us remember one thing, that in the midst of advancing technology, patients will remember how care was delivered. They may not remember the ultrasound, the point of care ultrasound machines that we have. They may not identify the sophisticated equipment that we are using, but for sure, they will tell someone about how they were treated by the care provider. And as I mentioned that, I'm just reflecting on my activities of the weekend. I had an opportunity to join the Lions Club in my village. And they were donating 2 wheelchairs to some 2 children. And when we went to the first family, I picked a bit of history. And this is a 19-year-old who cannot they cannot meet their activities of daily living. They are relying on their elderly grandmother who stays with him. And when I took a bit of history, the grandmother said that this baby did not cry at birth. And that got me thinking, would it be the actions or failure of action of a healthcare provider have led to this? And so as we care for mothers, as we care that they get newborns that arrive, let us also note we just don't want babies that arrive, but we want those that arrive and can also thrive. Because what we do can change the way a family lives, the lifestyle of a family forever. And therefore, let it be that each one of us here for every encounter that we are going to have with mothers and their newborns is going to be a blessing. I thank you all.
Thank you so much. Let us appreciate Anne once again. As I take this time to welcome the Director Nursing Services, Mombasa County, who will eventually welcome the representative from the CCM Health, Mombasa County.
Thank you so much, Madam Catherine. Midwives hoye! Midwives hoye! My name is Dora Mwambela, the Acting County Chief Nursing Officer. Of course, I'm midwife too. So, distinguished midwives, esteemed policymakers, colleagues, and friends, good afternoon. It's my profound honor to address you today at the 10th Midwifery Annual Conference under the pivotal theme, Midwives Collaboration for Resilient Health Systems. As the representative of the County Nursing Office, I stand before you committed to fortifying maternal and newborn health, grounded in leadership, strategic vision, and deep respect for your vital role. Each year, around 140 million births occur globally, with the proportion attended by skilled health personnel rising from 58% in 1990 to 81% in 2019, that is WHO. And despite the progress, maternal deaths remain stubbornly high, with high maternal mortality ratio still above 197 per 100,000 live births globally in 2023. Alarmingly, in sub-Saharan Africa, nearly 70% of maternal deaths are concentrated. Moreover, reduction in maternal deaths, 40% global decline between 2000 and 2023 are now under the threat from aid cuts, climate shocks, and fragile health systems. The evidence is clear. Universal access to midwifery care could avert more than 60% of maternal newborn deaths and stillbirth, saving 4.3 million lives annually by 2035. I draw inspiration from UN voices who have championed this cause: UNFPA, WHO, UNICEF, ICM, and JAPIGO, who launched the Midwifery Accelerator, placing midwives at the center of building stronger, more equitable, and resilient health systems. Someone said, this plan puts midwives at the heart of the solution. Now is the time for governments and donors to step up. Without investing in midwives, we cannot end preventable maternal deaths. Despite their proven effectiveness, midwives remain underfunded, undervalued, and inadequately deployed. In humanitarian and fragile settings, women are twice as likely to die in childbirth, and yet those areas account for 61% of global maternal deaths, while only 25% of live births occur. Now, more than ever, our policies must reflect evidence. So, therefore, we must invest strategically in midwifery, training, deployment, and support across all levels of the systems, integrate midwives into leadership roles in multidisciplinary teams, enhancing policy design and delivery and service delivery, ensure continuous resourcing, especially in fragile and rural areas, insulating midwifery services from aid volatility. Strengthen data systems to monitor outcomes, inform policies, and deliver accountability. Here in our county, we've seen remarkable success through midwife-led continuity models and community outreach. Your work has helped close delivery gaps, elevate antenatal care, and foster trust between communities and health systems. These models and the trust they build exemplify our path towards resilience. Ladies and gentlemen, we must act now to invest in midwives, to integrate them fully into resilient health systems, and to legislate robust support for maternal and newborn care. The time is ripe. The evidence is crystal clear. The moral imperative is undeniable. In the words of UNFPA leadership, to our member states here today, I ask you to prioritize reproductive, maternal, and newborn health and set clear targets. With your partnership, UNFPA believes that we can and will bring meaningful change. Let us stand together, therefore, with midwives at the center, building systems that protect life, strengthen equity, and deliver dignity for every mother and newborn. Let's ensure that no woman, no newborn is denied the care they deserve. Therefore, ladies and gentlemen, midwives in the house, as we sit down today to learn and relearn, let us enjoy, feel free to enjoy the beauty of Mombasa. You will enjoy, have different places you can visit. As much as you learn, just set time, ujienjoy. Karibuni sana, tumeshukuru nyote kufika hapa. May God bless you and thank you so much. And now I take this opportunity to invite Matron Mwanakarama to come here on behalf of CC. She will give her remarks. Thank you.
Thank you, Dora. Wakunga, habari zenyu? No, I'm so much excited when it comes to midwives. Huwa tunasema hivi na naamini sana that midwife is a very important person. Why? Because it's the person who meets us when we are coming to the world. It is the person who is welcoming us to the world, meaning that hakuna mtu ameingia hapa bila kupitia midwife. So mwenyewe ama nurse midwife, alafu tena naweza sema kwa lugha ya Kimombasa, midwife damu. Meaning that I really like midwifery, and through the experience and what I have done is very much valuable to the community and the mothers of Mombasa. So before I'm here to represent, my name is Mwanakarama Athman Mohammed. I coordinate reproductive health services. I'm here today to represent the office of our CCM and also the Office of Reproductive Health Program in the department. So, honorable guests, esteemed midwives, health professionals, development partners, ladies and gentlemen, good afternoon and assalamu alaikum. On behalf of the government of Mombasa and the Department of Health, it is both an honor and pleasure to welcome you all to our beautiful coastal city for this year Midwifery Scientific Conference. We are proud to host this important gathering of professionals who continue to champion the health and well-being of mothers, newborns, and families across Kenya and beyond. It is with a great humility that I stand before you today in this important covering, the Midwifery Scientific Conference, where minds, hearts, and hands come together to strengthen our collective commitment to reproductive, maternal, newborn, and child health. This is a timely and relevant conference under the theme, Collaborating into a Resilient Health System. So the theme could not be more appropriate as we reflect on the lessons learned from recent global and national health challenges, including pandemics, climate shocks, economic pressures, and workforce shortages. We are reminded that resilience is not built in isolation. It is built in collaboration. Midwives have always been at the heart of the resilient health systems. You are the first point of contact many women and families. You bring life into the world with skills, compassion, and dignity. You educate, you counsel, and you advocate. You are scientists, you are caregivers, leaders, and change makers. But when the most skilled and dedicated professionals need a strong system behind them for them to work. A system that is adequately staffed, adequately equipped, and funded. A system that listens and adapts. A system that integrates services across sectors and communities. That is why collaboration is vital. Collaboration between midwives and policymakers, collaboration between county and national governments, collaboration between health facilities and communities, and collaboration between science and practice. This conference is a space to such collaboration, a space to share evidence-based practices, innovative approaches, and local solutions, a space to listen, learn, and lead together. Let us use this opportunity not only to exchange knowledge, but to build partnerships that will outlast this event and truly transform our health system. As I speak as the County Reproductive Health Coordinator, of course, with a representation from the Office of CCM, I reaffirm our commitment to supporting midwifery, strengthening primary health care, and integrating reproductive health services into every level of care. We are committed to policy support, training, supervision, and the allocation of resources that reflect the values of your work. In closing, I would like to thank the organizers, the scientific committees, our development partners, and each of you who has taken time to appreciate in this conference. Your presence is a testament of your dedication, to your dedication. Let us keep collaborating. Let us keep building. Let us keep pushing for a health system that is not only resilient, but inclusive, equitable, and responsive to the needs of every woman, child, and family health. Thank you, and I wish you fruitful discussions and outcomes during this conference. Asanteni sana and karibuni Mombasa.
Distinguished guests, ladies and gentlemen, good afternoon. Good afternoon once more. Thank you, Mwanaharama. I knew I was coming next after you. And thank you, everyone. Welcome to Mombasa. I hope you are all enjoying the weather. My name is Janet Mogire. I'm representing the Ministry of Health, Division of Ramka. I'm so much delighted to be here in the 10th Scientific Mark Conference. And at the same time, so much humbled to represent the Division of Ramka in giving this speech. Therefore, I'm representing Dr. Serem. But overall, I'm here to congratulate you and tell you that you are awesome people in the country. Everyone respects you as midwives. And that notwithstanding, I would just like us to look at maternal health in 4 aspects, analysis that I know all of us know about. In terms of strengths, which strengths have we come up with in Kenya? What are our weaknesses? What are our opportunities? And what are our strengths? All that summed up together, therefore we can be able to tell where you as a midwife or me as a midwife, I am in developing this country. Step by step, I'll be very brief. Let's go through the steps. The strengths. We have policies that govern the country in terms of reproductive health, don't we? We have the Ramka strategic plan. We are doing a slow but gradual improvement in our maternal deaths. Statistics indicate that we are doing better than what we did in maybe the past 10 years. True or true? Yes, we are doing a good job. But then, we also have a midwife task sharing policy. 2017-2030, which helps us to expand the scope of care. We have sharing partners. We have the UNICEF, we have the WHO, among others I would not like to mention at this time. We have the community-based interventions that help us to refer our women from the community to our facilities. What are our weaknesses? They are internal, they are negative. We need to know them so that we strengthen them, so that we know where we are going. We are fourth in maternal mortality rates in Africa. How many countries do we have in Africa? I also don't know. Find out. If you're number 4, does that make us happy? Does it make us happy? No, we need to improve on that. We have large regional inequalities. I visit Lamu County and I realize they have to check on the tides before they refer a mother to the land area. I go to Homa Bay County and I realize the ambulance system is perfect. You realize the disparities that you're having. What is it that we can do to balance and merge these two? We have limited access to our BMOC and CMOC facilities. We still have shortage of staff, as you said before, skilled staff. We want skilled healthcare providers to take care of our women. We have stockouts. We experienced stockouts in our family planning contraceptive methods a while ago, and I think we are still experiencing the same due to the donor cutoff. We are likely to experience unmet needs to these reproductive age women. What about the opportunities? Thanks to the NCK, we already have midwifery training available. We have the Pumwani Maternity Hospital measuring on midwifery care. We have digital health. In the next few days, we'll be talking about OPOCA. Someone will be here to take us through OPOCAs. We have a lot of evidence-based practices that we need to embrace. Devolution, it has done well to some counties, yet in some counties are still dragging behind. What is it that you can do? That is an opportunity. We have the private-public partnerships for maternal health. The UHC, I know some of us may say, no, it's not an opportunity, but it is. In the morning, you saw the youths, and some of us were asking, are these youths in high school? Are these youths, have they just completed, are they in tertiary schools? Didn't you see the young girls here promoting attitude in our facilities? Yes, we are also encouraging the youth and the CHV's involvement in our communities. What are the threats, the negative ones? We had the funding cuts. It seems we have donor dependency. What are we going to do about it? We have socio-cultural barriers across the country, the geographical barriers, the long distances, our poor roads. We have insecurities in some areas, especially the northeastern areas. We're still burying our heads in the sand because of the unsafe abortions. We don't have clear line policies that cover our unsafe abortions. What about the disasters that we do experience? The brain drain. How many of us are still planning to go outside the country? Opportunities. How many of us are planning to go outside the country? Oh, none. This is interesting. I've just seen one. Thank you. Maybe I can cancel this brain drain. All these midwives are here to serve our Kenyan population. Thank you so much. I appreciate that. With the 4, the strengths, the weaknesses, the opportunities and threats, dear midwives, let's change our attitudes. Just like our youth said this morning. Let's change our attitudes towards our clients, towards our fellow colleagues at work. It takes a midwife to collaborate. And let us not forget about the newborn. With those few remarks, I welcome you to this 10th scientific conference and enjoy Mombasa. Thank you so much. Dr. Winja, you are the next.
Thank you so much. I want to take this time to welcome our DNS, Dr. Winja, so that she can give us her words of wisdom. Karibu.
Asante sana. No, there's no need. I'll go from here. My colleagues, sijui niwaite aje, yani mko watamu. I don't know the best word, but good afternoon, all of you. Good afternoon once again. Just stand up and stretch a bit. Now uambie mwenzako high five on my behalf. High five. On my behalf. Aya. Tukae. Thank you. Thank you very much. Aya, tuketi basi haya. People needed the switch. Okay, let's sit. I know you needed the stretch. There's no need. Okay. I know you needed that stretch. Tukae kule nyuma. Okay. So, okay, tusikize basi. Let's be attentive. Ladies and gentlemen, okay, ladies and gentlemen, I was actually told to talk on the status of career progression of midwifery in Kenya, which is doing perfectly well. And I will just give a few insights. They are projecting something, but there could be typo error here and there, but I will talk because I'm here. So nitaambia mtu tu ananiambia next, tunasonga next. Sindio? So I was told to talk on status of career progression of midwives in Kenya. And so much data has been given, and as we all know, data is critical. Data is very important. Data will give a way forward. Data will inform the policy. Data will make us move mountains. What people have never moved, but we can. So we shall see the presentation. There could be one or two typo errors, but I will talk from here provided you see. So on the outline, as you can see, it is there. I'll not be later on that. And on introduction, I'll also not talk so much because they have talked, but there are an estimated 29 million nurses worldwide and 2.2 million midwives. This one is from WHO. So they estimate a shortage of 4.5 million nurses and 0.31 million midwives by the year 2030. This is from WHO. So the global status of career progression for midwives is generally poor, marked by a significant lack of investment in education, training, and support. So many early career midwives often leave the profession due to lack of support and career pathway for development and specialization. And we have all seen through the presentation, there's no much support. We have partners on the ground, but I don't understand why it is not coming strong in Kenya. It needs to be evident, and Mark has really tried to move the wheel. They have really put the wheel on the ground to move, to walk the talk. I've also advocated wherever I am, but we really need huge support. So in America, midwives find growth opportunities through mentorship and in-service training as a specialty. While I just took also a study from Tanzania, where the growth opportunities are through advanced education via new training centers, specialized in-service training, and opportunities to practice in remote areas, the way we have always done. So next. This one I just took from the Globe and the WHO, the midwifery career pathway, where we have pre-qualification midwifery, the one who has entered for the first time. And then we have the clinical midwifery, the person who is now moving this is now for us, it is HND, the clinical midwifery. I took it from WHO. It is the HND, and then we go to specialization where we have research midwifery, clinical specialization, education, leadership and management, and finally we have the executive midwifery. This is the path of which I know we are also following as Kenya. We are moving on together in that way. And there have been quite a number of challenges. We move to the challenges. There's the ongoing shortage of midwives in many regions and the need to attract and retain qualified professionals. It has been said by previous speakers as much as possible, and I will tell you why. I'll tell you the reason what we are trying to do. And then there are challenges faced by newly graduated midwives, as we have said. They get problems, and even employment in Kenya becomes a very big problem. But we are in talks with counties. The COG initiated a talk so that we can see how they can also be absorbed, because they are supporting us in many ways. And there are challenges in retaining experienced midwives, including addressing factors that contribute to burnout, turnover, and dissatisfaction. There are barriers to implementing evidence-based practice in clinical settings and ensure that midwives have the resource and support they need. That's what we have talked about. We really need huge support for midwives. A mother should not die. We have seen quite a number of videos moving around in social media where people are complaining they are dying. There was that mother who was in Kayole 1. Just to move from Kayole 1 to go to Mama Lucy is about how many meters? Less than a kilometer, I think. But that woman stayed in that health facility for more than an hour, and she ended up dying because she could not just move. It's a very close distance, by the way. And that thing moved in the social media. I'm sure you all saw. We should not lose mothers at this era. Really, we shouldn't. We have just to think innovatively, out of the box. Lazima mtu atokelezee na jambo. Somebody has to come up with a very good innovative strategy. We have trained nurses on EMOG and midwives in EMOG. We have taken them for many challenge trainings and benchmarking. But I don't understand. As much as we have shortage, something needs to be done also. We shouldn't lose mothers, really, at this era. We shouldn't. So some of the achievements, there is a growing number of midwives taking on specialized roles as educators, researchers, managers, while still maintaining a strong clinical connection. Hiyo si ni ukweli? Is that true? Do you know we have one of the NEO member here who is a med soup? Did you know that? Did you know that? Did you know? Yeah. Oh, it's the MOH. But what does that tell you? Controlling a whole facility, institution. Clap for ourselves. Thank you. That is to show we are growing. We are actually growing, and that is a plus, and I'm very proud of that. So international collaborations, this is part of the achievement, and initiatives have led to promotion of best practice and support to the global midwifery workforce. Here we have somebody from ICM. We also go for conferences in ICM and many other countries, not only ICM, but we get so much from over and above. And a robust professional network with colleagues, joining professional organizations and attending industrial conferences. That's what we have said. This is part of our achievement, and biggest among all is technology play. Technology is a pivotal role in enhancing patient care and professional development in the digital age. And I know in midwifery we have leveraged electronic health records. I don't know why we are talking. Ama nikae chini. Please let us just be attentive for a short while. Nitamaliza na ni twende lunch. So while we are talking about this technology play, we also had a meeting with all county chief nursing officers and midwives last year. And we had a tool that Jebaiko really helped us to collect more data. And I'll tell you something that we are doing on this data. One thing that I can tell you is that this week and the week that comes next week, we are trying to develop the norms and standards for healthcare professions in Kenya. And we have experts from WHO, Brazzaville, and many others. We started on Monday. And first of all, we are checking on the WISM. Have you heard of WISM? Have you heard of WISM? Yeah, that is the Workforce Indicator Staffing Needs. That is the WISM. And it will tell us where there's shortage. It will tell us who is needed at what level of care, It will tell us because data was collected in all 47 counties in 2003. Now we are analyzing and coming up with the indicators. And this will tell us you need to employ because it's very clear. It's data which has been picked. And that's why I said data is very strong. It's very important. So this tool it's really extensive because the whole of Monday I was in class until around 6. We were working on it, how to enter, how to analyze, and it's really extensive. So it is this week and next week, and I really have to go back to support the midwives and nurses so that we get a proper deal on this, so that we see from the data that was collected, how can we present ourselves that there's a shortage. You know, when you have data, nobody will argue. It is there, and we have to do it. So that is bit of what we are doing. So in midwifery education in Kenya, actually diploma in midwifery was started like 6 years ago, but we have never had participants by the Nursing Council, and if she's here, she can confirm. 6 years ago, we have never had students. So we translated it to HND. And HND, I can attest, we have people getting to HND for midwifery. We also have upgrading of bachelors of science in midwifery, and we have quite a number. We have a number of nurses who are going for BSM, and then we also have new bachelors of midwives joining, and this is a big plus. Can you clap for yourselves? We have freshers, bachelors of science in midwifery, fresh. They have started joining in AMREF, in MUST. They are really joining. If you look at that, maybe I might have done a typo error there, but the truth of the matter is that now we are having, and this is a plus. In the diploma, they were not coming, but in bachelors, they are coming in numbers, and we are very proud of that. At least we have entry level of bachelors of science in midwifery. Okay? So, the expansion of midwifery education programs include degree, postgraduate, and we also have doctorate, masters, and doctorate, which is a plus. Now, this is the big monster in the room. Are you seeing career progression guidelines there? So, are you seeing the career progression guideline development here? What my brother Nyongesa talked about. Tumejipanga na tulikuwa ready to launch it officially in October. But I know all of you have heard what has happened. And this was a general statement from the COG. Mnanisikia vizuri? It was a general statement from COG, but we are in talks because we have letters that are inviting COG, and we have all that it takes. We have our director for health who is a nurse like us, and I told her, but you have been receiving these letters and you give us people. How come now you can say nursing and midwifery did not have COG representatives? So we are in talks, and I'm very sure we are going to resolve, and we launch as prepared in October. The most important thing about these career progression guidelines is that we did not have HND in the previous one, and we did not have masters. And this is where all of us are affected, both nurses and midwives. It wasn't there. So we have put some entry level. And all other entry levels have been raised up with one job group. Hata sioni mmefurahi. Vile tumekazana na hii kitu, from 2014 we have never had any. We have tried all our level best to push, and it has come out. And you shouldn't I mean, what I want to say is that I want to encourage you that this thing is going to work, because we have evidence that we included COG and we are in talks. So I'll be going there after next week because I'm doing the WISIN. I don't want any midwife or nurse to miss on this data. So after next week, we have agreed we meet and do a general letter that will, that will vindicate us from that general one. That is the one for. So about recommendation and future direction for the career progression, there's need for ongoing investment in high quality education and professional development for midwives. As you can see, that is that a midwife's impact lasts for life. If you can see that model there, which is very true. So we need to advocate for empowering midwives to take on leadership roles within healthcare systems and ensuring their voices are heard in policy and decision making. So there is also need to foster a culture of respect and support for midwives, recognizing their expertise and valuing their contribution, which is really, really critical. It's very important. So ongoing documents, as I have said, is the review of the norms and standards for nurses and midwives. Last one was 2014, just the way the career progression guidelines, the last one was for 2014, and we have an approved one for March 2025. And this is the one I'm talking about, norms and standards, so that we can know what kind of shortage we have, what kind of service is required at what level, and how many do we need at each level of service. It's the one I've talked about, WISIN. Do you remember what WISIN is? What is it? Workforce Indicator Staffing Needs. It's a very critical thing. You'll Google it later. Reviewing, ongoing again, we have reviewed and we have included midwifery in the quad. It was called quad, but we have to put midwifery to be part of this leadership. And this is part of what we have reviewed. And also review, revitalize, and restructure the Nursing and Midwifery Alliance. We had it, but it was dead, and we have to have that alliance to stand up again. So my part in short on this is that a midwife must possess the hand of a lady, the eye of a hawk, and the heart of a lion. This is my part in short. And that is midwives at your cervix. Thank you so much for that presentation. I know you will have questions of which I don't know what time I'll do. Okay, our nurses, our midwives. And so, ladies and gentlemen, as I stand here, I just want to inform you the Principal Secretary for State Department of Public Health and Professional Standards was very much willing to come to this conference. It is the 10th anniversary, and I only wish it was 10-10. Unfortunately, it is 10-9. So she was really, really willing. We were with her somewhere yesterday on the Patient Safety Day in Aga Khan University. And we talked and I convinced her, but I don't know whether it's fortunate or unfortunately, they had to go with the CS to Eldoret, but up to around 8 last night, she was very ready to come. So instead, she gave me her speech as the guest of honor and the person to open the conference to read on her behalf. So as a good servant, I will just read exactly what she was to say. I will not add anyone or remove. So I'm going to read her speech kindly. It is a great honor to address you today at the important 10th Annual Scientific Midwifery Conference, convened under the theme Midwifery Collaboration for Resilient Health Systems in Kenya. This gathering comes at a critical time for our country. As a nation, we are striving to achieve universal health coverage and to strengthen our health system in line with the Kenya Vision 2030 and the Kenya Health Sector Strategic Plan 2023-2027. The role of midwives is central to these ambitions. You are particularly important as we work to embed primary health care at the heart of our health system, ensuring that care begins at the community level and reaches every woman and newborn. The state of mental and newborn health in Kenya presents both progress and pressing challenges. According to the Kenya Demographic Health Survey 2022, our maternal mortality ratio stands at 355 deaths per 100,000 live births. While this represents an important compared to past years, it remains unacceptably high. Neonatal mortality stands at 21 per 1,000 live births, accounting for almost half of all under 5 deaths. The World Health Organization estimated that 87% of essential maternal and newborn care can be provided by a competent midwife. These statistics remind us of the urgency of fully empowering and supporting midwives. For if we do, we would prevent up to 2/3 of maternal and newborn death in Kenya. Midwives are more than caregivers. They are system builders. In rural and marginalized counties, you often serve as the first and sometimes the only point of contact for women and families seeking health care. You provide not only skilled birth attendant, but also family planning, adolescent health service, antenatal and postnatal care, and vital education on nutrition and breastfeeding. The Ministry of Health fully recognizes midwifery as a foundation of health service delivery. In October 2024, the World Health Organization recommended the adoption of midwifery model of care as a proven strategy to improve maternal and newborn health outcomes. We have aligned our national policies accordingly. The Kenya Health Sector Strategic Plan 2023-2027 prioritizes maternal, newborn, and child health as key pillars of UHC. The Reproductive Maternal, Newborn, Child, and Adolescent Health (RAMCA) investment framework identifies midwives as critical providers of high-impact intervention. Our UHC agenda ensures that skilled midwifery care contributes directly to reducing out-of-pocket expenses and increasing access to safe, quality health service. We are committed to expanding training opportunities, ensuring equitable deployment, and supporting continuous professional development for midwives. Under the National Nursing and Midwifery Policy 2022-2032, we have a comprehensive roadmap to strengthening the workforce, enhancing leadership, improving quality of care, and secure sustainable financial for the profession. Despite these advances, challenges remain, and Kenya continues to face workforce shortage. The WHO recommends 4.45 health workers per 1,000 population, yet our ratio is less than half of this, with midwives disappropriately affected. An equal distribution means that while urban centers are well served, many rural and arid countries lack adequate coverage. This issue cannot be ignored if we are to achieve the resilience we aspire to. Resilience is not built in isolation. It is forged through collaboration. For Kenya, this means fostering interprofessional teamwork where midwives, obstetricians, nurses, and community health promoters work as one integrated care team. It means strengthening county-national partnership, ensuring that counties prioritize midwifery in their budget and service delivery plans. Deepening partnership with the development agencies is also critical. Non-governmental organization and private sector actors to support midwifery education, infrastructure, and innovation such as digital health tools, while engaging community and building trust and awareness so that families seek care from skilled midwives early and consistently. On behalf of the Ministry of Health, I reaffirm our unwavering commitment to midwives and maternal health. We will scale up both pre-service and in-service training, ensuring competence-based midwifery education is widely available. We will improve working conditions by graduating the available to essential commodities, safe workplaces, and support supervision. We will leverage technology from electronic medical records to telemedicine and e-learning platforms to enhance the reach and quality of your work. And importantly, we will elevate midwifery leadership, ensuring midwives have a seat at the table in policy formulation program, design, and decision making. I'm pleased to announce that we will work towards establishing a dedicated directorate to give the midwives a chance. Let this conference be more than a dialogue. It should make the beginning of a renewed movement for midwives in Kenya to our midwives. Continue to champion professionalism, mentorship, and evidence-based practice in every delivery room. As we look ahead, let us commit collectively and individually to empower midwives, strengthening collaboration and building a health system in Kenya where no mother, no newborn, and no community is left behind. I thank you and I declare this workshop officially open. Thank you very much. I just wanted to read exactly her words, and that is exactly what I have done. So thank you so much.
Thank you so much. Again, let us appreciate our DNS for coming and representing our chief guest. Thank you so much. I want to take this time to welcome Sally so that she can take us through the next session briefly. As we can see today, we are celebrating 10 years since we started holding our scientific conferences and having our association. So welcome. Okay. Welcome, Dr. Sally, so that you can take us through. We again have a cake, so you will lead us through the session. Thank you.
Thank you very much. Thank you very much. I want to call upon my senior in terms of Mark to join me as we do the very key appreciation. I understand and know we do so much. So even as we do the appreciation today, we are demonstrating that it's very important for us to appreciate ourselves, even when we are doing our service delivery. One thing that I also learned when I was in clinical area is that appreciation does not mean money, because if you are handed 100 shillings, you will even need 200. If you're given 300, you will even need 1,000. So let's learn to appreciate one another. MAK, Midwives Association of Kenya, would like to recognize members that have supported us throughout the process, and also be able to recognize the teams that we've worked together, including the membership of MAK and other partners. Eunice.
Yeah, thank you so much. In my culture, they say when a visitor comes to you, you've got to give them something back. Sindio? When they come, and even when they give you a gift, a big gift, they come with a basket. Then you have to fill their basket back. That's how we do it in our culture. And therefore, we carried our culture to Midwives Association of Kenya by ensuring that we give back to the people we think who have really supported us. And in that case, we are not saying if you don't receive a gift, you've not supported us, you've supported us immensely. So we will share also a cake after. Is that okay? So we wish to recognize some of our partners, and I'll call upon Dr. Winja to come down, and the DNS, and even Michael, kindly, and Vice Chair to help us in gifting. Mm. So we wish to call upon Ferring Pharmaceutical. Are you around? Ferring Pharmaceutical, anyone representing Ferring Pharmaceutical? If Ferring is not here,
CRH, County RH Coordinator. County RH Coordinator, Mombasa County. Monica, kindly hand over to Nyongesa to hand over to the County RH Coordinator.
okay, thank you so much.
Turn it, okay. Thank you.
Asante sana.
Thank you.
RHNK representative. RHNK.
Chepieko.
CPHD, kindly prepare yourself to come. CPHD, kindly prepare yourself to come.
The VC to hand over to
RHNK. Thank you so much, RHNK.
JHPECO, Director Nursing Services, Mombasa to hand over to JHPECO.
CPHD, kindly, Director, help us, Dr. Winja, to give to CPHD. Asante sana, CPHD, for the support.
Luala, any representative
Chai.
from Luala?
Anyone from Chai, kindly come. So
UNFPA?
So Chai, the other side. CEO will give to Luala. Thank you, Luala, for the support. DNS will help us give to Chai. Thank you so much, Chai, for the support. UNICEF, kindly be coming. UNICEF. Then AMREF, if AMREF is around.
County Executive, CEC. The representative of the CEC was the RH Coordinator, Mombasa County, to receive on behalf of the
Thank you
CEC.
so much. Thank you so much. Thank you. Thank you so much. AMREF.
DNS, kindly hand over to the representative of the CEC.
Yeah. AMREF.
AMREF.
CEO.
That is representative of the CEC, Mombasa County.
Thank you. Thank you so much. Yes. So we wish also to appreciate our visitors who came to support us. And we'll begin with... No, mwisho.
Registrar.
Okay. Registrar, Nursing Council, the CEO for Nursing Council, kindly will appreciate you from the VC. Thank you.
Kindly pose for a photo.
Yes.
Look at the cameraman. Thank you very much. And therefore, I want to call upon the VC to step up front and stand squarely.
Yes.
Squarely. Assisted by...
So we will have the advisor, ICM, to help us to give the gifts.
To our... Yes, thank you very much. We will have the chief advisor together with our vice chair to hand over our gift to the DNS, Dr. Awinja.
Yes.
Please come on.
Yeah.
And pose
Thank you.
nicely. Look at
Thank
the
you.
photo.
Thank you.
Thank you, thank you, thank you, thank you, thank you very much.
Yeah.
To KPNA.
KPNA, okay. So, KPNA, the president of KPNA, yeah, thank you. Thank you. Yeah. The DNS for Mombasa, kindly, the VC. Yeah.
Thank you.
Thank you so
Thank
much.
you, thank you, thank you so much. Thank
Thank
you
you.
very much, and please don't leave.
Ngoja kwanza. Monica. So we want to appreciate also our visitor from the ICM, kindly, from the VC, from the RAMCA department, kindly come. Yeah, thank you so much for coming. Thank you, we appreciate. Yeah, then RAMCA. Asante sana. Thanks for coming. Asante.
Thank you. Just before the cake cutting, I would request yeah, this one is yours. Yeah. I would request our guest to kind of step a bit here. The photographer would like to take a photo together with the national executive, and kindly someone to call for me Jane Baluka downstairs. I wish you could hear me, but she can't hear. Mombasa team, kindly call for me Jane Baluka.
Yes. Wewe unakaa katikati. Director wetu pia. Okay. So kindly come. Come. Oh, Joe? Okay. Which step? Step what? Please, pange. Okay. You want a cover? Okay. Okay.
Thank you kindly. Come up front. I want to call upon all the county directors, nursing services to come over for this ceremony.
We made a little bit of an error. We've forgotten one of our very important partner as well to recognize, ACAF. Kindly, we've not forgotten you. We will, but you can come to the front for a greeting. ACAF, please. Kindly come.
So kindly, the County Director Nursing Services would like you to come up front to assist our chief guest to cut the cake. Busia County, I saw the County Director Nursing Services. And can I also get the County RH coordinators? County RH coordinators. And I would like to have one regional representative, and that can be from Mombasa County. And the Mombasa County Regional Rep, please come up front. The branch chair, Mombasa branch, please come up front. The farthest, one member from the farthest, munipatie. Man member from the farthest, tuko na mtu wa Busia. One member from the farthest, ni wapi? Lamu. Do we have someone from Lamu? One member from Lamu, come over. So we have an opportunity of cutting a 10-year this cake is a 10-year remembrance that we are now at 10 years old. I call upon Monica to organize for us this cake. As sweet as it's going to be, is prepared for our own midwife, Monica Munyendo from Mombasa County. Therefore, we'll also be having a feel of the sweetness of one of our own that has been able to make this. We are celebrating the 10 years being there as MAK, and we totally want to appreciate that we've been able to reach 10 years. And we're praying to God that He will enable us be able to grow and more in terms of growth, expansion to many counties and even membership. So as she's organizing our DNS, we are happy today to announce to you that Midwives have been able to walk this far. This is a nice cake, sweet enough, with all the colors of Midwives Association of Kenya. And therefore, we will be able to, each and every one of us will have a taste of it. So allow me to call upon our Director of Nursing Services, Dr. Winja. Please come over. Before that, can we hand over the bag so that we are free from the hands?
Yes. Somebody from ACAF? Yes, thank you.
Thank you. Yes, make sure you capture that photo. Yes, so we have our DNS supported by our DNS Mombasa and DNS Busia County. Kindly, plus our chief midwife, where is she? Our international chief midwife, please come over. Let's all come around and support Dr. Winja as the cake is being cut. Plus our vice chair, Catherine, our MOH, Catherine Fuguta Sienji. DJ, kuna kata? DJ, niaje bwana, zetu kata tu hivyo. Or we can do it ourselves because tunaweza fanya. Aya, kata. Kata keki kata. Kata keki kata. Kata sio ugali. Kata. Kata keki kata. Kata. Keti ya midwives kata. Kata, kata. Kata keki, kata. Weka kwa sahani. Kata, kata. Tunataka kuona DSS akikula keki. Thank you very much. So can we have the cake being cut? The first person that will be given the cake is our DNS, who today is honored as the chief guest. We totally appreciate that you had time for us today. And therefore, from our vice chair, our MOH, Catherine Chienji, kindly feed and give the cake to our chief guest, Dr. Awinja. Tafadhali wacha Eunice akate, wewe upeane. We are seeing our VC, Catherine Chienji, giving the lovely cake from Midwives Association of Kenya to Dr. Awinja. DJ ni aje leo bwana. Thank you very much. We totally appreciate that. We want to, our VC again is giving our co-registrar nursing council. Utamu ndio hiyo, hata kama tunalipa pesa ya registration, lakini tuna mpaka tukule. Thank you very much. Yes, please. Yes. We also are aware the Director Nursing Services Kiambu is around. Please come over here and receive this cake. And yes, and I call upon Mombasa team to kindly the President KPNA is being given the cake by our Vice Chair. The photographer is requesting that you look at the photograph. Tafadhali, this is going to be in part of our website. Tafadhali, Director Nursing Services, Busia County is receiving the next cake. Yes. And please, the next one is going to be our chief midwife ICM. Please come over and receive the cake from midwife advisor Zab. Karibu tafadhali, we would like you to have a cake from our vice chair. So vice chair, you will turn your hand. Behind you is our chief advisor. Chief advisor, kindly give the cake to the chief advisor as the Mombasa team are making sure that you will all eat the cake. Thank you very much. They are smartly dressed today. We totally appreciate your uniqueness in Mombasa County. And thank you. From there, we will, Eunice, kindly assist to give the DNS, Kiambu, and the RH coordinator. And Mbaluka, kindly assist to give to the RH coordinator, Kakamega County. And yes. Thank you very much. Mombasa team, kindly let's make sure this cake reaches everyone in the room. Let everyone taste the sweetness of, and please make sure you also taste. Because kuna namna ya kukula bila kutest mwenyewe. Thank you. Let me also get the cake so that I don't miss out. Yeah. Thank you very much. Let's have our visitors up so that we can finish the session. Let's have our visitors up front so at the dais we can finish the session.
for your lunch. So we will ask someone to volunteer to pray, or maybe I'll pray for lunch. But before I pray for lunch, I would like to offer the votes of thanks as we continue eating the cake. So I wish to, on behalf of Midwives Association of Kenya, so on behalf of Midwives Association of Kenya and our chair who is not around, Dr. Tekla, I wish to thank the following people. The Little Theatre Club for entertaining us with a very good dance, and also the skit that was very good. I wish also to thank our photographers for the wonderful job they are doing and doing a live video on your YouTube. Thank you so much for the good work you are doing, Tom Pix and your team. I wish to also thank the sound engineers and the mixer that are seated there. Thank you so much for the wonderful job. And for all of you who have attended this meeting, I wish to thank you. All the planning committees, thank you so much for making this happen. To our partners, let us keep on moving maternal newborn health. To the NEO, thank you so much for making this happen as well. And all the guests that are representing different departments, asanteni sana, and let us continue partnering for the future and also collaborating. I wish to thank all the associations that are represented here. Let us collaborate for the better of healthcare system in this country. So I wish to pray so that we go for lunch. Father, I thank you for this day. Naomba tuombe. Tuombe tafadhali. Nasikia kelele. Let us kindly pray. Let us kindly pray. Father, we thank you this particular day. We thank you for Mombasa team. And we thank you for all the midwives that are gathered here, all the partners and other healthcare professionals that are gathered here, and even non-healthcare professionals that are here. Father, we pray that God, you bless each one of them. And as we go for lunch, we pray that God, you may bless our lunch, and also that the food may nourish us and may help us to be more healthy. I thank you and I worship you, God, because you are faithful. In Jesus' name we pray. Amen. Thank you. You are free to go for lunch.
Make sure you test our cake. It's big enough.
Good afternoon, midwives. I'm Marilyn Chebi from the Nursing Council of Kenya. We're humbled to be here this afternoon. There's my colleague, Collins Wamunye, please. Yeah, so we have a presentation on the advanced midwifery practice in Kenya. We appreciate the specialist midwives we have in our country. From the Nursing Council regulating the nursing and midwifery, want to speak about what we have in advanced practicing midwives. My colleague will be joining me. So we appreciate so in the presentation, we'll be talking about the training, midwifery and neonatal. We have the nursing and midwifery, so we'll be talking about the midwifery. We appreciate the 10th anniversary the MAC are celebrating. So we'll be talking about the regulatory tools supporting nursing and midwifery training, current state of APM in Kenya, benefits of APM practice, and way forward. Hello, colleagues. Tell your neighbor, shh. Thank you. Let's hear something. Let's hear about the advanced practice midwives. That's the way to go for the midwives. So allow us to give you an highlight concerning the various cadres. We appreciate the progression pathway from the lower to the higher level. In a data nutshell, that we have we appreciate the every year nursing council producing nurses and midwives, and currently we have around, you can see 165 registered nurses and midwives. And in the register, we have around 7,222 nurses and midwives. We have the registered midwives, 5,600, and every year it's swelling up. The registered nurse midwife, 875, bachelor science midwifery, 91, and midwife neonatal, 187, 14 neonatal critical care midwife, neonatal nurses. And in the emerging progression pathway in NCKs, well, we embrace the higher diploma, which is coming up, and we encourage many nurses to uptake the higher diploma for those who want to progress from diploma to higher diploma, which is upcoming. We're very happy that our DNS mentioned that. We have the advanced practice midwives, where the epitome lies on the specialists of midwifery. And we are happy to inform you, we've been asking of the special register. We are on Thank you. I'm happy my registrar is here. Karibu sana. We have the specially register, which the nurses and midwives have been asking, and soon the register will be ready. We are at the finalization phase, and I'll encourage that when we'll ask you to come, please run very fast and have you be registered in the specialist register. And we have the license in clinical capacities that we are developing for our clinical people and clinical specialists. So in a nutshell, NCK has worked to have various regulatory tools to support our nursing, our midwifery and nursing. We have the scope of practice for the entry level, where the nurses midwives diplomas lies, bachelor's midwifery, advanced practice midwifery, and among us there are many. We encourage that all the midwives kindly visit our booth so that you know more about your scope. We have clinical procedures in nursing and midwifery, which is guiding us in our clinical and education. We have clinical procedures in advanced midwifery practice. We are happy to inform you, APMs, that the manual is on course, and soon you'll have the clinical manual for APM. We also have code of conduct and ethics for nurses and midwives, documentation care handbook for nurses and midwives. We also have standard of nursing and midwifery education and practice, which is guiding us in our academic, the teaching and the clinical. And we are happy also to inform you that we have revised the uniform guidelines so that we maintain our professional image of nurses and midwives, and can encourage you to visit NCK and you have a copy. Current state of nursing and midwifery in Kenya is that we appreciate that nurses and midwives form most of the 70% of the workforce, and we are responsible for the various healthcare indicators. Beyond all the service delivery is a nurse or a midwife. Highly qualified midwives tend to move into management and education, and this calls for action for us to spread wide and balance in also the clinical areas, as we appreciate those who are in management and education. And there's still opportunity for advancement in clinical practice. As you know, that is a challenge when somebody wants to advance in midwifery, maybe releasing and all that is a challenge, whereby we really appreciate the counties so that the midwife can grow on their specialties. There's need for specialists in advanced midwifery practice, having that the nursing council, they ask all the regulatory tools for this, and we encourage midwives if they can take this pathway in their specialist. Current state of advanced midwifery in Kenya, as I said, as the ICN 2020, that advanced midwifery interventions influence clinical healthcare outcomes for individuals, families, and a diverse population. So when we have an advanced midwife practitioner, they're able to handle wide and large health issues, having that specialties. Advanced midwife practice are forming roots with that we have the supportive regulatory development tools, we have the scope of practice to guide them, and also the procedure manual. Currently, we have 3 universities that are undertaking the program, and I know many are coming on board, and also we encourage many to come on board to embrace specialist midwives. Autonomy and goodwill is in the practice of qualified midwifery. We appreciate that the APMs are able to have the autonomy to handle various emerging issues and makes healthcare better, and also that there's recognition through the register for the APMs so that at least they can have that recognition and also appreciate what the competencies and the specialists they have. Benefits of APM is cost effectiveness. When we have these specialists, it makes healthcare because they're able to handle even in the level 2, 3, and before referrals, they are many to handle many issues, making cost effective better. It also increases access to specialized care, increases disease burden, decreases disease burden, improve healthcare outcomes, increase patient satisfaction. Survey has shown that patients and clients like to be handled by midwives or nurses, and we appreciate that. It also reduces hospitalization and reduces maternal, neonatal child mortality rates, and it also embraces midwifery consultancy as the APM have the autonomy through the scope that they can practice and have consultancy at the various levels and better our healthcare. It also increase the bargaining power for nurses and midwives and improves mentorship for midwives in clinical practice. Our way forward is that there is need to create policies to support training and practice in APM, whereby the institutions or the hospitals are at least to have that autonomy for the specialists, midwives, practitioners. And there's also a need for market demand and employment of the APMs, and we really encourage that and through counties, organizations, so that the midwives, advanced midwives can be recognized and at least they can make better health care in the delivery of their specialist care. Thank you. I submit back. Thank you.
Can we all give an organized round of applause? Thank you so much, Marilyn. Marilyn was giving us an insight on advanced midwifery practice, that is master's level in midwifery. Just kindly pack a few questions if there are at all, so that after the second presenter we can have a few questions before we invite our last presenter. The next presentation will be on feasibility and acceptability of peer support interventions for women following obstetric fistula repair in Kenya. This will be presented by Julie Nyanchama. Julie, karibu sana. You can just. Karibu sana, Julie. Julie is a senior research administrator at KEMRI. Oh, she's getting prepared for the stage. She's a senior research administrator at KEMRI. Also study manager for maternal immunization readiness assessment. She's a nurse midwife, currently pursuing a PhD in clinical research in maternal neonatal health at the University of Nairobi. There we go. A round of applause as she takes the stage. Karibu sana.
Thank you very much. As you've heard, my name is Julie Nyanchama. I'm going to take you through a feasibility study. We are looking at feasibility and acceptability of community-based peer support intervention for women following obstetric fistula treatment. Welcome. Next slide, please. Obstetric fistula is an abnormal connection between the bladder and the vagina or the rectum that may develop after protracted, difficult labor, resulting in urine or fecal incontinence. 2 to 3 million women are affected with obstetric fistula in sub-Saharan Africa, 1,500 annual cases in Kenya, and 90% of these cases also involved stillbirth. The key issues among women who have received obstetric fistula treatment include high stigmatization, far-reaching physical, social, as well as economic consequences, limited support for social reintegration following obstetric fistula treatment, and peer support potential remains unexplored. This study was actually done in Kisii, Kenya, and our target population was women who had received obstetric fistula treatment. Our primary focus was to improve social reintegration using community-based peer support intervention. Next. This was a mixed method feasibility using a pre and post design intervention for a period of 6 months. We recruited 32 women for this study. We had 10 peer supporters. We also used the sense of belonging tool to actually assess their pre and post sense of belonging. And then we also did in-depth interviews pre and post intervention. The intervention took a period of 6 months. Next. The results, since this was a feasibility study, we approached 39 women. 32 of them were enrolled in this study. And out of the 32, all of them were retained up to the end of the study. The intervention was successfully delivered through 1,847 minutes phone calls with 92% contact success. Proceed. So for the results, under the social belonging scale, we saw that there was reduced psychological isolation, that is SOBI scale, that is sense of belonging scale. And then there was also enhanced social affiliation at the end of the study. Variability decreased substantially across subscales, suggesting consistent effects across all participants. This is just a synopsis of how the sense of belonging scores were for the 32 participants. Proceed. For the qualitative data, initially we were able to pick up a few themes. Initially, women normalized obstetric fistula. They thought it was just a normal occurrence. And then there was also financial disempowerment among the women who had fistula. During the post-intervention evaluation, there was social reconnection and acceptance, and there was also progress in socio-economic vulnerabilities. So, for example, one of the participants said, my husband also left me, chased me away, and married someone else before fistula. And I used to farm, but now I no longer farm because I have no access. So I'm struggling to resume my previous activities, which gave me a sense of belonging and independence. So these women really need to reintegrate, but however, the challenges in between have become an impediment. Next. Inconsistent support. There was also emotional and psychosocial recovery. There was coping and resilience among these women. And then there was empowerment and leadership development, where we had a few participants becoming women group leaders after this intervention. So the key findings, there was significant improvement in psychological belonging, enhanced social affiliation and connection, decreased variability across all subscales, and consistent positive effects across all the participants. For the qualitative, there was improved self-worth and enhanced coping mechanisms, increased participation in socioeconomic activities, growth in community leadership roles, and significant emotional healing and reduced stigma. So some of the strengths of community-based peer support intervention, under feasibility and acceptability, the telephone-based model was suitable for resource-limited settings, high participant engagement, as these participants requested for continuation of that peer support, scalable intervention design adaptable to various communities, sustainable framework for long-term implementation. For community impact, there was broader community benefits through awareness creation, stigma reduction in communities. Then there were participants actually now became health advocates following this intervention. We were also able to create a ripple effect beyond direct participants. And then there was enhanced community understanding of obstetric fistula through this community-based peer support intervention. So in conclusion, the community-based peer support intervention proved highly feasible and acceptable for women following obstetric fistula treatment. And the evidence demonstrates the power of shared experience in healing and recovery. It informs large-scale intervention design and implementation and provides strong evidence for incorporating peer support models to comprehensive obstetric fistula treatment programs. Implications, under clinical implications, we have integration of peer support into standard obstetric treatment protocols, holistic approach addressing both physical and psychosocial needs, training programs for peer support facilitators. And then under policy, there's need to support community-based intervention models, resource allocation for psychosocial support services, and integration with the existing maternal health programs. And then we also have, for the future research, we need to do a large-scale randomized control trials, cost-effectiveness analysis for peer support models, long-term follow-up studies for sustained outcomes, adaptation for other cultural context settings, and integration with digital health platforms. Thank you very much. I want to acknowledge University of Nairobi, my supervisors, as well as the stakeholders who are the midwives, the mothers, and the post-fistula treatment patient. Thank you very much. I want to acknowledge my funders, that is the UK government under LSTM program. And before I conclude, I also have a different program. We'll be discussing it under maternal immunization readiness assessment. I'm the study manager for this program in this country, and we'll be rolling out new maternal vaccines in 2026. So stay tuned up to when I'll do the presentation. I think it is on 10th or 11th. Welcome. Thank you very much.
Thank you so much, Julie. A big round of applause, kindly. Thank you so much. I want to take 2 questions from each before I invite a panel discussion. Any question for the Nursing Council of Kenya and for Julie Nyanchama before I invite a panel of discussion? Any question? Thank you. That presentation was on point. Thank you so much. Sorry. On to our next discussion that will be integrating female genital mutilation prevention into routine service delivery. This is a collaborative nurse-led model for resilient health systems in Narok County. Allow me to invite Omolo Fidel. Allow me invite Omolo Fidel. And also to invite on stage ACAF, a panel from ACAF. ACAF. As they come on stage, David C, PhD. Kindly see Eunice Asali. David. I'm waiting for the ACAF to come on stage as I welcome Omolo Fidel. Omolo Fidel is a BSN from the University of he's also a nurse intern at Mama Lucy Kibaki Hospital, a beneficiary of ACAF anti-FGM training. He's also worked with ACAF on projects that integrate FGM prevention, are passionate about health innovations, leadership, and research. Karibu sana, Omolo.
Thank you. Good evening. As mentioned, my name is Omolo Fidel. I'm going to be presenting on integrating FGM prevention into service delivery points. This is some work we did in Narok sometime with Africa Coordinating Center for Abandonment of FGM. So in my beginning, allow me acknowledge ECAF. You'll allow me acknowledge the University of Nairobi. Allow me acknowledge the county government of Narok for allowing us to do the work in Narok. The Narok County Health Management Team, the Nairagi and Kare Health Facility, that's where the model FGM model health facility is, and Professor Kimani, who is our integration lead, and also the TGGLM, who are the funders. So for starters, FGM was described yesterday, and I'll just continue from that FGM is a violation of human rights, and it has no health benefits. So while the national prevalence of FGM has fallen to 21% from 21% in 2014 to 15% in 2022, there are some counties that still face some high rates. For example, Narok has a prevalence of 51% of FGM. And in line with our theme of resilient systems, those systems must address both visible and the hidden forms of FGM, especially with the emerging trends of the medicalization of FGM. And midwives are better placed. We are always at the front line of giving care. So we are better placed to assess FGM risk. We are better placed to identify FGM survivors, manage the complications of FGM, and now being in the front line makes us, midwives, the key agents on prevention and care of FGM. So natural practice, there is no screening of FGM in our health facilities. There is no proper documentation or structured FGM-related interventions, including even the health messagings that we give. They don't majorly touch on this topic. So a bit of background on ECAF. So ECAF is building the capacity of the next generation of midwives and nurses to be able to end FGM, and they've established a model of care. So they provide technical support and mentorship through the FGM training that personally I underwent in 2024 at the University of Nairobi. And then they facilitate a pilot placement in Narok County to expose the students, the trainees, to a real-world FGM dynamics. And as I've said, the prevalence of FGM in Narok is very high. So we are placed there. And in Narok, ECAF have also developed a model health facility at Nairagi and Kare County Health Facility. So it has the model health facility where FGM can be managed. And then they also collaborate with other CSOs. So at Nairagi and Kare Model Health Facility, what we do is we did FGM screening, and we incorporate the FGM screening into ANC, maternity, and child welfare, and the family planning clinics. We have data tools to collect data on FGM. We also give culturally sensitive health talks at the waiting bays as people are waiting to be given care. We would go there and talk about FGM. And then we also gave counseling and risk assessment during the consultations. There was a point where we would ask the mother, we were assessing sort of the risk of the particular mothers cutting their girls. And then we also went to the community that's beyond the facility. We had household visits together with the CHPs to assess FGM risks and deliver health education. We did school visits targeting adolescents, and we would give motivation and also age-appropriate messages and also survivor testimonials. And then we also had youth engagement through sports. I'm sure my team will cover a bit of that in a question. We engaged the males specifically and also the youth through football tournaments to be able to reach them in non-clinical spaces. And then we also gave culturally relevant messages that sparked dialogue and also challenged the myths that they have about FGM. And then the community members were encouraged to voice their experiences and report cases. And then these are some of the voices that we got from the field. I'll start with the one. A student during one of the school visits at St. Anthony Girls Secondary School, a student described how nowadays FGM is conducted in a clean environment and are given clean sheets. Everyone has their own news couple. And this type of FGM is the medicalization of FGM, where now we have healthcare workers being the ones performing the FGM. And this is a reality that we saw in the field. And then the one in green is an experience from a mother who was cut, and she described her pain during FGM as excruciating. So as a result of that, when she was giving birth, she had a very tough period with that. And after that, she decided to go get an IUCD, so that she may not be able to have kids again. That was a testimonial in Lelongo village. And then one other is a mother who, as much as we know about FGM, there are people who still don't do it, not by virtue of knowing the harms or the consequences, but they do it because they fear the law. So I feel if people would know the actual message, they'd do the right thing. So in line with our theme about resilient health systems, the outcomes of what we saw is that midwives led the integration of FGM into service delivery points. And then we created safe, culturally respectful spaces for clients to open up. And then we provided psychosocial support, especially for survivors, and also with the childbirth trauma, as I've said, and also acted as the liaison between the households and the schools, and also the CHPs and also the facility. And overall, it's a way of strengthening the links between the various systems. And the lessons we learned from this are that midwives are trusted messengers, and that makes us the ideal vessel for sensitive topics, for example, as FGM is. And then embedding FGM care into daily service delivery makes the system proactive and not just reactive. Makes the system anticipate rather than react to a particular situation. And then cultural competence is vital as clinical skills when building resilient systems. And youth-led midwifery efforts can bridge gaps in hard-to-reach areas. And in conclusion, this model from Narok demonstrates how midwives can integrate FGM prevention and care into everyday service delivery. So I believe this is doable in our various facilities. And linking health services with the community engagement, midwives can prove to be the heartbeat of resilience and a rights-based health system. And we, the midwives, we are the heartbeat of a resilient, rights-based health system. And as I conclude, every contact with a woman or a girl is an opportunity to prevent FGM. So finally, just an image of our various experiences at the facility. Thank you so much.
A big round of applause once again. A round of applause, round of applause. Thank you so much, Fidel. And right about now, I want to take you to a great panel of discussion, the brain behind prevention of FGM, and also integration of FGM prevention activity into our service delivery. Kindly allow me invite Jacob Okumu to take us through the session. Karibu sana, Jacob.
Hello, ladies and gentlemen. Good afternoon. Good afternoon again. I know the afternoon sessions can be a bit heavy. Please bear with us. This is going to be an exciting conversation with a lot of lessons. And to kick off, I know the topic of AGM has been discussed a lot during this conversation, starting from yesterday and today as well. And one thing that I take personally is that every time you're in the communities, you'll hear people referring to FGM as a cultural practice or a religious practice. But the reality that we continue to interact with shocks us, in that we continue to witness grave human rights violation, sexual assault against women and minors, text of culture. And there's a lot that has been achieved. But even so, there's so much that can still be done. And there's a lot that is happening. So today we have a great panel that is going to share with us the amazing work they're doing in the efforts to end FGM. So without wasting so much time, please, ladies and gentlemen, help me welcome this great panel with a round of applause. Great. So this time I promised the team here that we'll manage time better. And to ensure that is happening, I will have my panelists introduce themselves as they dive into the topic. And I will start with Professor Kimani. You, Professor Kimani, as you introduce yourself, please share with this team what ACAF is doing together with the Girl Generation Africa-led movement to end FGM.
Okay. Good afternoon. Thank you, Jacob. I'm Professor Samuel Kimani. I work for the University of Nairobi. And in the University of Nairobi, we have a center called ACAF. ACAF stands for Africa Coordinating Center for Abandonment of FGM. In ACAF, we are also in a consortium. And the consortium is called the Girl Generation Support to Africa Red Movement to End FGM. And some of our partner members are here, Jacob from Options, Kirigo from Orchid Project, and we have other partners like University of Portsmouth in UK, AMREF, ActionAid, and we work in 4 countries. And these countries are Kenya, Somaliland, Senegal, and Ethiopia. And our mandate is basically to intervene in the community, at the community level, intervene at policy level, but even more importantly, advancing human rights of women and girls through working through structures and systems. So in that consortium, ACAF is mandated to implement what we call integration. And integration here means integration. It means for a long time, FGM has been addressed as a standalone, and we think that is not sustainable. So our model integration means that in the development programs, for example, health, education, peace and security, can we have FGM being part of that? And that is the model that we are looking at. And why integration? Integration is an innovative approach which has sustainability in it, because we know, for example, health systems will never cease to be there. They will continue to be there. And therefore, within the service delivery points where women interface with the health system, they need to have FGM care in terms of prevention and response. So that is what we have been doing. how have we been implementing this? Our implementation pathway is multi-level, multi-layer, multidisciplinary. And one of them is we implement at national level, and at national level we develop curriculum and training materials, because we don't take for granted that healthcare workers do understand what FGM is, including medicalization. So we have helped in the Ministry of Health to develop policy documents and also training manual as well as curriculum. But also within the national level, we work with the universities and colleges. Why? Because we want the next generation of health human resource, to be competent, knowledgeable, and champions against FGM, including medicalization. And that is why, for example, in my panel here, you have students who are in the medical school, you have lecturers, and you also have the product from there who are also doing intervention in terms of internship. So that is at the national level. Then we also work at service delivery point. And this is where now the midwives are very key. At service delivery level, we work in service delivery point that interface with women and girls who either have complications arising from FGM or who will be interfacing with girls who are at risk of being going through FGM. And these are antenatal clinic, family planning, child welfare clinic, maternity, and labor ward. So those are the areas where we are integrating. But even more importantly, we are also cognizant that youth-friendly services are also within our health system. So the young people are the most vulnerable, and therefore we are also integrating there. And then we have another layer, we are talking about the community. So we ask ourselves, you cannot win the war against FGM if you don't include the community. So, and who are working there? The community health promoters. So we make sure that we are capacity building for community health promoters so that they can be able to help in prevention, but even more importantly, they can identify women with complication, refer them to the health facility. So our model is multi-level, but it has also an innovative pathway where we make sure that we complete a whole loop. Because we believe systems don't work in isolation. They have to work as interconnected, and everybody must fall into place. So that's how we have been working, and I'm happy that within the national, at the policy level, we have worked with the county government, and that is why I'm going to pass over, for example, to one of our colleagues from Narok County. We have made sure that we train students in the universities and colleges, but even after theoretical training, even using simulation, we have now placed them in a model health facility. So we have developed a model health facility for offering what we call supermarket kind of services in form of FGM prevention and response. And we have developed a model health facility in Narok County. I'll let my colleagues speak to that. But underpinning our model, first of all, is collaboration and partnership. That's why we can't win this war if we don't collaborate with midwives and nurses. And we think this collaboration has been running for the last 4 years. We have, every year we have had an opportunity to share with you guys, and we have seen the passion when it comes to sharing our findings. The second thing that also underpins our model is knowledge sharing and learnings. Because if you implement a project and you don't share the findings, then nobody is going to pick up this. Because we want other stakeholders to be motivated to pick our model to replicate in wherever they work and also scale up. The final one is mentorship. Of course, you have seen the young nurses and the midwives who are qualifying from university. We need to support them to also go to their communities and also develop the mentality of motivation and championship against this model. And the final one, of course, is making sure that we capacity build and strengthen systems through data, okay? So in that model health facility, when women come, they are able to be counseled, they are able to be supported psychosocially, and we have a model we call safeguarding. And safeguarding here is very key. Of course, we saw the skit in the morning here, and it has a lot of safeguarding issues. So we want to remind healthcare workers that we are custodian of do no harm, and professional ethics and fidelity to professional ethics is one of our fundamental requirements. So safeguarding in whatever we do, we make sure that we don't re-traumatize women who have undergone FGM. We take care of girls who are at risk of FGM. So in a nutshell, that is what we do. In integration, I'll let my colleagues speak to it. And one of the persons that I want to speak is the county reproductive health coordinator, Madam Nene. Over to you.
Great, thank you, Prof. So, Madam Nene, as you speak, also share your experience on how the FGM integration model and partnership has shaped the delivery of reproductive services, and especially in Narok County.
Thank you. I'm Esther Nene, as he has said. I'm a sociologist, nurse, midwife, coordinating reproductive health services in Narok County. The integration model has assisted Narok County in many different ways. In one, it helped us train our healthcare providers to know how to handle these ladies who have been FGM, how they help the mothers and relieve them from this pain of FGM. Also, it has helped the healthcare providers. They have been trained about 200 healthcare providers and about 10 trainers of trainers. So it's not ACAF leading, it's the county government leading by training these healthcare providers. In training the healthcare providers, we also train the CHARs who in turn train the CHPs. The CHPs have been trained and they know how to refer these mothers to the healthcare facility. In our healthcare facility, the model healthcare facility is the one and only healthcare facility, the one you heard Fidel saying it's in Nairobi and Kare in Narok County. It is the only one in East and Central Africa where a lady can walk in and see how her 1% is deformed and see and also be counseled and agree to be at least rectified. It is the only facility where all FGM and other services are integrated and women go there in numbers. We started with 10 mothers, but now you will get the numbers. There are over 3,000 mothers. In a day, they go there until the facility is closed because the time is over. But they are still waiting for they also wait for the services. It's not only for family planning. They go for checkups. It's a facility where all mothers go there, and it's not a referral facility. They go there because of the services, because of the need to know how they can be rectified. They are suffering from FGM. In this facility, this model facility, we also have students, mid-level students, and university students. This is a facility where students come in where they have never seen a person who have been FGM, but in this facility, they learn practically. They see how to do the defibrillation, how to help this mama give birth without a lot of bleeding and complications. In this facility, we have that lab where students are being taught how and what is what, the types that from type 1 to 4 of FGM. And again, in Narok County, we've partnered with colleges, as I said, the mid-level colleges and the universities. This is where they bring their students for learning, because we all know that it was not in our curriculum. Even when we went to school, FGM was a topic of 30 minutes. But because we are rich in culture, Narok, we have advocated through our partner that it is included in the curriculum of other mid-level schools and universities. When they come to our facility, they see that this is the real FGM, not in books, but a person working who have been done FGM. So the students who pass through our county really appreciate the work in that facility. Another thing, we also integrate with, as I said, other schools, and this model, it was only this year, February this year, when we hosted the High British Commissioner because of this model. She came to see what we are doing in Narok County, because when we say PPH in other counties, we think of other things, but in Narok, when we say PPH, most of the times we think of FGM, because in our county, most of our mothers, 30% of our mothers deliver at home. So with FGM, what happens? The mama will crack all, like map of Africa, map of Kenya, think of it, all over. So she will come bleeding. But if only she can come early and we do the defibrillation and we conduct the delivery, all can be well. That's why we are trying to advocate the issue of telling these mamas with FGM to come to hospital early for defibrillation. Another thing, the model in Naregankare. With our partner, we've been trying to at least spread the gospel to all our sub-counties. We are hoping that with time we will spread the gospel of that model facility to all our sub-counties, because even our county government of Narok have seen what the model and the integration is doing wonders in how the model is doing wonders in our county. Another thing, in Narok County, it's not that the partner is doing this work, it's us, the county government employees, plus the students who have come in. Our partner is only giving us the knowledge and the skill. That's why we have trained most of our healthcare providers, and we are continuing. In fact, next week we'll be having another class of 30 the healthcare providers, and also another class for CHPs, so that they can refer more mothers, because in my county, Narok County, almost 51% of the women have been FGM. So we are trying to curb this issue, because you find that if they give birth at home, you will have things like fistula. Some come with the problem of keloids. So we are trying to curb this problem by spreading the gospel of FGM, or telling them to deliver in a hospital. Thank you.
Let's appreciate that. Thank you so much. Dr. Chebet, welcome as you introduce yourself. Please discuss with us how can midwifery and nursing curricula be strengthened to equip students with knowledge and skills for FGM prevention.
Thank you very much. My name is Joyce Chebet. I am a lecturer at Aga Khan University, and I'm also a member of ACAF. And when it comes to strengthening the nursing and midwifery curriculum, and even other curricula, probably the medical and clinical officers curriculum, it is important to think about how do we use this curriculum to impart knowledge and skills to the students. And as Nene has already talked about, the students have a chance to manage women and girls who have undergone FGM. So one of the things that we can do in ensuring that we have strengthened our curriculum is to ensure that we add content of FGM. I know the nursing cancer syllabus has allocation of some hours, but maybe the hours may not be adequate. ACAF has developed a curriculum that is able to help impart knowledge not only to the students but also the trainers. And it's a 2-day curriculum that can be implemented, and the students can get more knowledge specifically on management of FGM or women with FGM complications, and also how to prevent. So that is one way we can strengthen our curriculum, by ensuring that FGM content is included in it. 2, we can strengthen our curriculum by equipping our skills lab. Yesterday we had a demonstration on defibrillation. And for a student to be able to perform defibrillation, they should be able to have knowledge and skills on identifying, so learning about the normal, and then if there is a client who requires to have defibrillation, then they have the skill. So our skills lab should be well equipped so that we are able to share those skills. When these students go out and they are able to manage the mothers, they're able to identify and manage them as they manage them in the clinical area. The third thing is we can continue partnering with other people as we work with the curriculum. So sometimes you may invite guest lecturers in your institutions just to give a speech or speak about FGM. That is one way also that we can enhance the knowledge and skills for FGM. We have so many resources that we can reference as training institutions. WHO website, for example, we have a number of resources that we can use. For example, we have a clinical handbook that is very well documented and highly summarized, and it's easy to make reference to. We have job aids and so on. So those are some of the resources that could be used in strengthening our nursing and midwifery knowledge. Thank you.
Thank you. Thank you. On to Teacher Gilbert. What is your experience in implementing ACAV and FGM curriculum at the mid-level colleges?
Right. Thank you so much, Jacob. My name is Gilbert Sige. I am a senior nurse midwife. I teach at Tenok Hospital College, School of Health Sciences in Bomet County. I'm also the deputy principal. I'm here to share my experiences working with ACAF to implement this FGM curriculum. And I want to say from the onset that we've been able to partner with ACAF. Initially, they were able to train 2 of us as the TOTs. Then from there, we were able to pick up the assignment. We took the curriculum and the training tools. We went back to our institution. Then from there, we were able to start or initiate the first training for the first cohort. I'm happy to report to you that as we speak, we have trained more than 80 students. And in those trainings, we were able to run a 2-day training as prescribed by the curriculum, which is given by the ACAF. And I would like to say that this training has really created a lot of curiosity from the learners, the students who have been learning. In fact, I have one of them here who is a beneficiary from our college. So I will going to respond to that question in 2 folds. One, the training has been successful. It has been impactful because we've been able to reach to those number of students I have said. And the support given by ACAF, by facilitating students and training materials and content have also been very helpful. From there, we've been able to send students again to the model health facility that has been mentioned by the previous speakers. And I want to say that even as we speak right now, our second cohort of students are rotating in that facility, and they've been able to enjoy, they've been able to face real life situation, what's happening in Narok County. So I would say that this training has been very impactful. We are very thankful with the collaboration we have had with ACAF and UN, and without them, our students would not have learned much about FGM. As my colleague has said, the content that we usually deliver on FGM is just negligible. It's just talking about the types of FGM. But with the curriculum, which is standardized, it's able to give us elaborate details, matters dealing with complications of FGM and other content. Yes, so up to that level, I would like to appreciate the collaboration and partnership. And I think this is in line with our theme for this year's Midwives Conference, which is collaboration towards resilient health systems. Thank you so much.
Thank you, thank you. Dr. Ellen, what's your experience in supporting the medical and health professionals and their trainees, including midwives, in knowledge and skill acquisition, and of course the translation of the same into quality sexual and reproductive health and rights for women?
Thank you so much. There's Jacob. So as Jacob has said, my name is Helen. I'm Sankaine. I am a midwife and a clinical support for ACAF, who is able to support ACAF activities in Narok County
I run the model health facility by making sure the model facility is able to integrate FGM prevention services into the normal delivery services that are given at different service delivery points. So I'll pick from where the mid-level and universities, institutions of training have done. So when the students come to the facility, we are able to receive them, and we are very lucky to have a very equipped skills lab that has a lot of models and ways that students can relate to real life situations before they are able to cascade and give quality services to our women and girls at different service deliveries. So at the Skills Lab, we are able to mentor students to be able to give culturally sensitive messaging and also to be able to soften their skills to be able to give quality care of women and girls who are survivors or even at risk of FGM. So when we receive students, so far we have received over 100 trainees from both mid-level colleges and universities. That is, could be nursing students, medical students, clinicians. All of them are able to come under my mentorship and also the mentorship of the other staff who are all trained. That in the model health facility in Eragenkare, all the staff are trained and they are able to give mentorship as also as they offer quality care in restoring dignity of women and girls. So from the service delivery points, we are lucky through ACAF to have more detailed data collection tools. As midwives, we've interacted with a section in the MOH books that normally ask about FGM. But now with ACAF's tool, it has more details. You can be able to ask more questions and collect more data on on FGM, and that has also provided a way of counseling, because you would have built a rapport with your client. Maybe let us say a client has come to maternity or antenatal. During your service delivery time, you're able to collect data, asking the woman about her status and also having an opportunity to confirm by physical examination on their status, and then give a talk. For example, when you're after delivery, you are able to link, like maybe the complication that has arose is because you've had FGM. Then this is a time as a midwife you're able to protect the girl that you are delivering by letting the woman know the negative effects of FGM, and then you can be able to talk to them, and eventually from that, women can definitely change and protect their girls. And so we have also, model facility, over 4,000 women have gone through our hands, and all of them counseling is done, and also quality care is given to them that is culturally sensitive and that is restoring dignity to our women.
Thank you so much. And I'm being reminded of our promise to keep time. So Fidel, Felix, please let's be as brief as we can. And starting with Felix, what innovative approaches, very briefly, have you applied in engaging communities in the effort to eradicate FGM?
Good afternoon. I'm Felix, and I'm a proud student beneficiary worker. And today, we just want to thank Chaco for that question. Well, when we talk about the innovative approaches, it is not even about the technologies or even the gadgets. It's just about exploiting the spaces and being creative. During my placement in Narok, what I learned is ending FGM need creativity. And as students, we were so intentional and very, very deliberate on this issue. And one of the approaches we used as an innovative approach was even organizing football tournaments. We realized when you go to household visits, you don't find men in the homes. They are found in beaches, in towns. So we try to be creative. So we converted the beaches just to be a classroom. We organized the That was very. And then another thing, another innovative approach was on churches. During weekends, we could go to churches, fellowship with youths, attend Bible studies, and we realized that when you empower these people, they carry their messages home, and they feel that sense of unity. So as students, while you were there, we use every open spaces, because if we are serious about ending maternal mortality, then we need to be serious about ending FGM. And then another thing, we used to organize Mbuzi Joma. We realized men love a lot of nyama so much. So, and when they eat nyama, they stay for dialogue. They cannot just rush home. So we use that moment just to talk to them about the harmful practice of FGM. And it proved very effective, because you could measure even during the behavioral response. And then another thing was on those survivors. We have those survivors of FGM, and we empower those ones. Because innovation only is not even technology, but the ability to speak up, because so many people are not even speaking up. They are silenced, and they cannot even report any issue. So we empower those people because they are living witness. They know the health impact of these FGM practices. So those are the main innovative approaches as students that we used to employ, and it proved very effective. So in a nutshell, midwives are not just caregivers, but they are innovators. Thank you so much.
Thank you so much. And Fidel, so that we wrap up with Esther, after gaining the experience from ACAV, how are you able to apply those knowledge in other counties and area of practice?
Okay, as I initially indicated, I'm currently doing internship, and with the training that I got at the University of Nairobi on FGM prevention through the ECAFS model, and also a beneficiary of the model health facility at Nairagi and Kare, and currently I'm at my internship, and we have two ways that we've thought could be some ways that we can spread the information. One, during the introduction bits, we had a lot of ward in charges in here, the DNS, the county directors of nursing services. Most of you are here. And for our internship placement, one of the requirements is community health. And when we come knocking to your offices requesting to be placed in areas that FGM prone, so that you can go and exercise the particular knowledge that we learned, kindly don't bar us from that. And to our ward in charges, we have the knowledge. We intend to spread it even among us, the nurses and the midwives in here. So when we come and request for CME sessions to be able to talk about FGM and share the knowledge that we have, we really appreciate when they are granted. So those are two ways that we can, us as beneficiaries, can continue spreading the gospel. Thank you.
Thank you so much. Hey, is that all you can get? Let's give a better clap. All right. So as you finish, and then we wrap this conversation up. I know it's a heavy afternoon. Please share with us how the midwives, this is considering it's a very vital audience, how they can move from the clinical setting into becoming advocates for ending FGM.
Thank you, Jacob. So my name is Keri Gojenga. I work on the advocacy team at the Girl Generation Africa-led movement to end FGM. And I think when we think of advocacy, it's about influencing. It's about changing people's mind through education, through awareness raising, using your research, using your convincing skills, all of that to really get people to where you want them to be. And in this case, the issue is about ensuring that we are ending FGM. And I think from each of these speakers, just to summarize, I think you can see the advocate in them. And I think Felix really summarized it very well in saying that midwives are not just health practitioners. That's not the only job that you do. You live in communities, and FGM is not just a health problem, it's a social problem. It's an intersecting problem. It intersects with education, it intersects with at this point, climate change, where, as we know in most of our communities, at least in Kenya, FGM is a precursor to child marriage in certain cases. And of course, the whole dowry conversation and how that happens. So if you think about the setting in which you live, your job is to really influence within your sphere of influence. As midwives, we have influence in our communities. We have power in our communities. So those women that you're speaking to, those community members that you're speaking to, really do take your knowledge and your experience seriously when you speak to them. And that is where you need to think of how you place yourself in this community. So I know our panel has spoken around community engagement, those innovative measures that, that Felix was talking about, the school engagement that he's talked about, collaboration with influential leaders. It may be religious. For example, if you're up north in Kenya, FGM is more considered a religious obligation. If you're down in Narok, Kajiado, it's more considered a cultural obligation. So where are you? In what space are you? And who are those people that you can influence? But I think my sitting here is more about how you influence in spaces of power. So you need to speak to Madam Nene because she's dealing with sexual reproductive health in Narok County. And you need budget for this because I think, like with everything else, FGM as an issue around maternal mortality, then you'll need to be speaking to Madam Nene on how you can get budgetary allocation, for example, through the county budgetary allocation. But let's think about national advocacy, for example, because that's more relevant to where we are right now. Are we aware that the Anti-FGM Act is under review? Hands up if we do. Okay, not very good. But that is under review. And the reason why I bring that up is because one of the things that has been criminalized is medicalization. So you as a midwife, if you're found to be committing, aiding or abetting, handing around tools, whichever act you do that is promoting FGM, then you are in trouble. The old act said life imprisonment. But we realized that some of the sanctions that we give may drive the practice in the negative direction. So the review is also about thinking how we can ensure that we are encouraging people to comply, ensure that we're encouraging people to report, but also encouraging midwives, doctors, other health practitioners to also give care as what is happening in the model health facility. And so now we have 3 years minimum and, is it? I think seven years imprisonment, right? As a minimum. So you also need to think about, as a community of midwives that really want to engage in this issue and ensure that we have girls and women who are healthy, who do not have to suffer sort of the consequences of FGM, how do you promote the law? But also, how do you get involved in this policy discussion so that, for example, you can give your opinion on why 7 years, right? Health facilities in the review right now will be fined and closed, right? You work in health facilities, so if someone's discovered doing it, like all of you, get the brunt of it. So how do we involve ourselves in this conversation whereby our voices are heard as a very key stakeholder in this journey of ending FGM? So public participation is coming up on the bill. So please, maybe I can just ask the MARC officials to really just engage with members. Dr. Chebet is here, Professor Kimani is here, around what is happening. Because we have put you down as a key stakeholder to engage around the bill, around medicalization, around the offenses, around the penalties in the bill. We need to hear everyone's voice around this bill. And then, I know we don't have time, so allow me to conclude by saying, you work with CHPs, you work with traditional birth attendants. Again, this is your spheres of influence. So be in those communities and train, be in those communities and yield the power, call it an imbalance, whatever you want to call it, wield the power that you have to influence how people think of FGM. They may not know the consequences. So please use your voices and your power and your influence in that regard. And maybe a rallying call, as Dr. Nene said, spread the gospel. I think you start by standing up and being a role model in terms of being very clear that you are against FGM, right? And shouting up and loud about it. but maybe cautionary, because in some communities, in some localities, you also need to safeguard yourself, right? It's not everything that you go around shouting, so be very careful of your context, ensure that you're safe and you're also taking care of your well-being, even as you advocate for an issue that I would hope you're all passionate about. Thank you, Jacob.
So my last clap for awesome. I hope you have braved the afternoon, the lure of the afternoon nap to listen to this amazing conversation. And I hope you have questions. So my brother here is going to move around. We get 2 or 3 questions for the panelists to respond to, then we are happy to call it a day. So just raise your hand if you have any question. Okay, we have 1, 2. He will also observe gender balance. Awesome. And also in the interest of time, let's appreciate my panelists here. I will only have, thank you, awesome. I will only have 1 panelist wrap up the questions so that we don't keep you here so long, and then we call it a day.
Habari za jioni. Kwa majina naitwa Shindo kutoka Kilifi, gatuzi la Kilifi, nikiwa nasimamia mambo ya ukunga upande ule. Swali langu linakuja kwa Bwana Fidel na Felix. Wakati ulipokuwa ukitufahamisha, nimeona kwamba mambo ya ukeketaji ilikuwa 21 kwa 100, ikakuja 15. Lakini katika eneo lile la Narok ukasema bado ni 51. Felix ametueleza mbinu zile wanafanya kuifanya hii hali iteremke chini. Hata bado ya mbinu hizo zote bado tunaona ile idadi bado iko juu. Pengine kuna tatizo gani ambalo mnakumbana nalo ambalo linaifanya hali hii haijateremka ama haijakubaliwa katika sehemu zile? Asanteni.
Thank you. There was a hand right behind him.
Good evening, everyone. Ningependa kuendeleza msururu wa lugha kama mwenzangu wa Kilifi. Swali langu haswa ni kwa Fidel. Mmekuwa mkisema kuwa wauguzi ama madaktari wanawekwa sana katika kukabiliana na ukeketaji wa watoto wa kike. Mmefikiria kuanza masomo wakati wanapoanza kuwa watoto wachanga ama kama miaka 4 wanapoanza kujielewa, ndio ili wajue kama mtu anataka kunikeketa ama anataka kufanyiwa hilo tendo ni vibaya kwangu. Yafaa ianze kwa wao wenyewe. Inafaa muanze kuwafundisha wao wenyewe, manake nina uhakika tuseme sehemu ya Narok wanaume huwekwa kando wakapatiwa mafunzo ya kuwa wanaume, wanapatiwa mafunzo ya majukumu. Mbona msichukue watoto wa kike muwaeke kando, muambie kuwa haki zenu ni hizi, hamfai kukeketwa, na ianze katika umri ukiwa mdogo sana. Si kulimbikizia wauguzi ama madaktari kuambia mbona mlifanya hivi. Ianze na kina mama nyumbani kuwafundisha wasichana wao haki zao. Manake mafunzo yanaanza nyumbani. Kwa hivyo mwanamke yote atakapojifungua mtoto wa kike atakuwa yajua ni jukumu langu mimi kwanza kumfundisha kuwa ukeketaji ni mbaya. Kwa hivyo ianze kufundisha watoto wakiwa wadogo hawafai kukeketwa. Wasiwe wafike umri wa kubalehe ndo anaanza kujua kuwa ukeketaji ni mbaya. Tuanze mchangani kabla ifike juu kwenye jua. Asanteni.
One more.
Thank you very much. I want to say that the fight against FGM has really taken quite a long period of time. And I just wanted to get some clarity with regard to the policies and regulations against FGM. Yes, I was saying that the fight against FGM has been on for a very long period of time. And the regulations and the policies against FGM have been there and they are still there up to now. I am wondering what other innovative ways we can be able to strengthen the regulations that are in place just to ensure that we are able to curb FGM. For example, when I look at FGM, it is a resemblance of what we see against sexual and gender-based violence. The regulations are there, the culprits are there, but the support from the legal perspective in terms of punishment, in terms of, ensuring that the law takes a root may not be as strong as we feel. Thank you.
Thank you very much for those insightful questions. Well, let's bring in Professor Kimani to respond to some of those.
Thank you very much, members, for those wonderful questions. I'll speak to them because most of them are cross-cutting. And I could move beyond East Africa because we speak Kiswahili. And I see this is an international meeting. We have our international colleagues around. So I think the first person did ask about the prevalence. So in Kenya, the prevalence of FGM among women in reproductive health age, 15 to 49 years, is 15%. 15%. What that means is statistics, whatever, 101. You go to Nairobi, stop in Kenyatta Avenue or Mombasa here, drop a net, pick 100 women, 15 of them will be cut. That is how we calculate the prevalence. That is national. Sub-count, in terms of county, because we do have the KDHS 2022 data, it shows some counties have as high as 96%. For example, Wajir, Mandera, Garissa, 83%. Come to Kajiado, 24%. Go to Narok, 51%. So the question is, even within Narok County, that is what you'll be getting in the Narok town. But if you go to deeper areas where you have homogeneous population, like among the Maasai alone, the prevalence could go as high as 80%. So these differentials do exist. So are we seeing any drop? Yes, we have. In Kenya for the last 15 years, when you look at the cycles of KDHS, the numbers have kept dropping by almost 5 percentage points. What has contributed to this? It is, one, the legal environment is very conducive. Kenya has a prohibition of FGM Act. The constitution is very clear about FGM is fundamental, it violates the fundamental rights of women and girls. We have policies that are very good. We have presidential support. I think the current government is very proactive in making sure that FGM ends, just like gender-based violence. So those are some of the intervention. And of course, good work by the CSOs, the NGOs, and also professional organizations. So there is no single intervention that can brag to have reduced the prevalence. It is a multifaceted approach involving multiple interventions everywhere, here and there, and when they sum up together, then the prevalence comes down. That is what I would say. But specific to Narok, I think in Narok we have extremely supportive administrative system in terms of the law, in terms of working with other sectors, in terms of the support. For example, the health department in Narok is very supportive, and also the gender department. Those are some of the good interventions that have led to the reduction of FGM. The second speaker did ask, why don't we start targeting the young girls? already there are programs, especially targeting school-going children. But we also know the interventions that we have put in place have been so successful, especially when you target the older girls, about 10 years and above. So what has happened? When you target these girls, they become empowered and they have the agency. So that empowerment, they are even refusing to be cut. So communities have now devised mechanisms of making sure that they target younger girls, because those ones don't have agency, they don't have the information, they are more vulnerable. So we are urging stakeholders, when they come to intervening around FGM, you must be innovative and you must understand what are the drivers. Yes, we are not blaming the healthcare workers, but statistics are very stubborn. In Kenya, the prevalence of medicalization is 14.7%. And this is, if you do a microanalysis, you find that the midwives and the nurses are the biggest culprit. Not personalize anybody, but that is what the statistics are saying. But we also know that data has its own issue, because anybody who works in a health facility, you put on a white coat, wewe ni daktari, you are a doctor. If you put on a dress, you are a nurse, you are a midwife, even if you are a cleaner. So if you pick up a surgical blade and anesthesia and a needle and you go do your things out there, the nurses and midwives and doctors will be blamed. So we also know the limitation around that data. So, but the most important thing is medicalization is happening. We need to be more professional. We need to adhere to the legal banning around the law that is banning FGM. And then the last question is around how can we have more innovation in addressing FGM? I think for me, I could speak from health perspective. Part of what we are doing, integration, is an innovative approach. And we are likely to win this war if we go out there, because healthcare workers are more respected. Communities are likely to listen to you. Let us start this war from where we work from. The rest of the people will follow our model if it proves to be successful. So I'm happy to say that the law is there, is very important. It gives the foundation for other interventions, because I can tell you, for example, in a country like Somaliland, we don't have even a law against FGM. And what happens? FGM is 99.1%. In fact, they tell us you cannot get anybody who is have not undergone FGM. In fact, when we do prevalence statistics, we even say it could be 110%. Because most of these women in those countries, they actually even come back for refibrillation, which is a form of medicalization. So that is what I would say. Thank you very much.
Let's appreciate the panel. Thank you so much for the exciting. Please give them a good round of applause, please. All right, so as we exit, thank you so much, everyone. Thank you for listening. Please, let's do a small exercise. Please take up your phone. Let's do this for us. Please take up, as an appreciation, please take out your phone, please. Take out your phone. Go to your browser. Go to your browser. Google. Ama enda kwa Google. Kama browser inaleta shida. Naeleweka. Enda kwa Google. Then type www.thegirlgeneration. That's a one word. www.thegirlgeneration.org. Now, when you get to the website, navigate to the resources part. And when you get to the resources part, navigate to the global goods. You will find some of the amazing publication that this team has put together. Some of the questions that were being asked could easily be responded to by going through some of those resources. They're in all the languages that you can get, especially for us in Kenyans, they're in English. If you are French speakers, they're in French. So please interact with them. Feel free to print out and use it even for continuous learning. Otherwise, thank you for listening to us, and may you have a good afternoon.
Thank you so much. And as the panel is taking their seats, can we give them a big round of applause? Wait. That is not enough for a team that is led by Prof. Can we give them a Nyayo style? 1, moja, mbili, tatu, nne, funga, funga sana. I want to appreciate each one of us for the patience that they've exercised throughout the afternoon session. We were already feeling at the beach, but we've changed and we've brought ourselves back to the conference. As we wrap up the day, allow me invite Dr. Sally Oronje to close for us today. Thank you so much. My name is Jack Kotonda.
Thanks, Jack Otonda, for that wonderful time. I will not close, but allow me to mention a few issues that are very key for our tomorrow. Thank you very much, ACAF, for that wonderful panel discussion. I don't want to miss to say out that ACAF have worked with us, and we have had several webinars in terms of series to ensure that midwives around Kenya have been able to learn more in terms of FGM. We have had several series of webinars. We totally appreciate ACAF for their support led by Professor Kimani. Thank you so much, and may God bless you, even as you ensure that many other members get to understand and know more in regard to FGM. Tomorrow we have 2 panel discussions. Allow me to make you aware that we will have 2 panel discussions. One panel discussion will start at exactly 8 in the morning. That will take us 45 minutes in this main hall, and this is under the Center of Public and Health Development, and that is the point of care ultrasound for early pregnancy screening. You wouldn't want to miss this because this is very important for the midwife. The second panel discussion will be that will follow will be a twin panel discussion by Ampli, and the discussion is going to be introduction of recently recommended life-saving postpartum hemorrhage products, real-world implementation experiences in Kenya by Ampli PPHI. It's important because that is a key area in terms of midwifery. Many mothers are dying because of PPH. So that will also be a panel discussion. Together with Ampli PPHI, we will have Luala Alliance, and they're going to focus mainly on optimizing the use of NASG. For those of us who have had an opportunity, or for those of us who will yet to have an opportunity, I know the team that were there yesterday felt it. So it's important that if you can join us, optimizing the use of NASG in PPH management. This will also bring about the lessons learned from various counties, and more specifically Homa Bay County. So those are the plenary panel discussions that we will have in the morning, and we will also be able to have a keynote address from a very key partner to us just before we get into the breakout sessions. In the morning, we will announce the various breakout stations in regard to the topic so that you can be able to choose where you would love to join in. Again, we have poster presentations. Poster presentation is part of scientific presentation. It's only that not all of them can be presented because of time constraint. So tomorrow we'll talk about that. If you have not handed in your soft copy of your presentation, kindly see the scientific team desk and ensure that you hand over your presentation early so that it can be loaded for ease in terms of track A, which is going to be here, and track B downstairs. So at this time, allow me to call upon. Thank you, Lamek. So the following presentations have not been brought ahead. That is Jacinta Katungu If that is not your name, you forgive me. But Jacinta, 2 Lidi Dulo, 3 Pauline Nafula, 5 Sam Okumu, Eva Nyakonyo, Nyakongo, and then Mary Kwambai. Kindly make sure your presentation, your soft copy presentations are with the scientific team for ease tomorrow morning. Allow me to usher in our Vice Chair, just to give us a blessing even as we go to relax in the evening, ready to learn tomorrow, because most of the time tomorrow will be learning sessions. Please be here to ensure that you are able to carry home some evidence-based practices and some new information that you can be able to take home. Thank you and be blessed.
Thank you so much, Dr. Sally. And I want to appreciate the teams that have presentations this evening. I know after lunch there is usually a very difficult moment to sit in a class. I appreciate you because up to this far, most of us are still seated. Thank you so much for being patient with us. As we come towards the end of the day, one thing I would want to share with you is tomorrow we'll be having our gala dinner, same venue in the evening starting from 6 p.m. When you come in the morning to register, we are charging 1,500. Unless advised otherwise, unless we get somebody overnight to support us as we register in the morning, let us register for our gala dinner, which will be in the same venue. Thank you so much for the day. I would request that we all stand and end this day with a prayer from a volunteer. Somebody who is touched, please step forward to pray for us so that we can end this day. I want to wish you journey mercies wherever you are going to rest. Those who are able to take a break and walk at the lake, the sea, the beach, yes, this is time. And I say tomorrow we will have a gala dinner just at the beach. Thank you so much and God bless you.
Thank you so much. Good evening. Shall we pray? Our kind and everlasting Father, we want to thank you, gracious Master, for this precious moment that you've given unto our lives. Thank you, Jesus, for you had planned this day, and Jehovah, you wrote it in our hearts, that one day we shall converge at this place, be impacted with knowledge, and go back to our community, impact them all, Jehovah, Lord. Thank you, Jesus, for this moment. Even Jehovah, Father, for the day which we have spent well. For the remaining 2 days, we want to commit them unto your able hands, so that you may be able to guide us and walk with us, O King of glory. Gracious Master, we stand be guided because of your Holy Spirit. Thank you, Jesus. We want to acknowledge that maybe we are sinners, or we are sinners in one way or the other. We want to pray for forgiveness of our sins, O King of glory, because we believe that once we are cleansed, you are going to hear our prayers and you are going to heal our nation. Thank you, Jesus, for you are going to depart from this place to our various destination, King of glory. Gracious Master, we want to pray for journey mercies, King of glory. When you see tomorrow we have converged at the same venue with the same hearts, even Jehovah glorifying your name, and even fulfilling the ultimate goal of you creating us, which was to glorify yourself in us. Through the mighty name of Jesus Christ, we shall always remember to thank you. In Jesus' name, we praise, trusting, and believing. Amen.